Harsh, please start your presentation.
A very good morning to good evening to all the teachers, my seniors and my fellow mates. Myself, Dr. Utkarsh Ravikant from FH Medical College, Agra, is going to present my paper on the topic 10-year follow-up of cemented total hip replacements in patient aged between 40 to 60 years old. So as we know, the arthritis is cases of arthritis are increasing day by day. So this is a survey of Canada showing the in 2015 it was done, in which the 54 million people were already affected with arthritis, and the projected were in 2040 is 78 million only in Canada only. And this is a graph showing that with time the incidence of age people with in between age 50 to 60 years, the people will get increased incidence of arthritis. This is a graph showing that a comparison of patients with rheumatic complaint between the Malaysian, Indian, and Chinese people. The complaint in the Indian females in age 40 plus is more than that of other, while complaint in males less than 65 years age. So what is the need of total hip arthroplasty and when it is needed? So it is needed mainly in primary osteoarthritis or in secondary osteoarthritis due to avascular necrosis, sequelae of childhood infection, or in rheumatic arthritis, etc. So we have three options when taking in account for total hip replacement. One is uncemented, one is cemented, and other is uh, hybrid. So our goal, our aim of the study is to know the survivability of the cemented arthroplasty in 40 to 60 years age and to assess the functional outcome of the patient who underwent the cemented total hip replacement. Material and method, the study was of retrospective type and the time of period of study was between January 2010 to 2020. Inclusion criteria, the patients coming with hip pathology like avascular necrosis, rheumatic arthritis, osteoarthritis, septic infective sequelae, aged between 40 to 60 years and with low functional demands. And the exclusion criteria consist of less than 40 years and or more than 60 years, developmental dysplasia of hip or bone defect in the acetabular or femoral femur component, or with revision surgery. So the procedure, the approach was used was posterior Moore approach, and the patient position was in lateral. And the failure signs, the femoral loosening was defined by the Barrack's grading, and the progressive radiolucent line two or more Chanley-Diller zones were considered the sign of loosening in the acetabular component. And definite implant position change or migration and eccentric wear of the cup were also considered the sign of implant failure. So the outcome were measured by visual analog score or by and by Harris score. So the result, the patient were operated between 2001 and 2010, and follow-up was done between 2020 to 20. Total number of patients that came into our study were 36, in which the 11 patients were lost during follow-up. And out of 25 cases, minimum follow-up was of 9 years. And out of 25, 17 were males and 8 were females. And predominantly, it was of right-hand side. So this is the images showing sequential images of total hip replacement cemented after 1 year, 2 year, 5 years, 7 years, and 10 years. So these are the scores at 6 weeks, 3 months, 6 months, 1 year. As we see at after the 10 years, it was Harris score was around about 92, and the VAS score was 1, which is pretty decent, and Harris score was came into excellent group. So the complication, we had 3 cases in which one of them, the acidobulum, there was no interdigiting of cement in bone and with normal femoral component. In one, there was aseptic loosening of the left femur, and in second one, there was lucency in the cup, showing slippage of the cup as compared to the earlier radiograph. So discussion, as we know, there is a debate that either to use cemented or cemented better or cementless are better. So some authors say that the performance of the cementless component is equivalent to that of the cemented, while others say that then the cementless shows superior results with time. So conclusion, in our series, it provides evidence of a good long-term survival of the cemented hip arthroplasty in adults between 40 to 60, and cemented arthroplasty can be taken as an account in the back of the mind in younger age group also. Thank you.
Very nice presentation, Dr. Utkarsh. I would like to ask two questions.
Yes, sir.
One is, why did you exclude patients more than 60 years of age for cemented hip arthroplasty? And second, whether it is a prospective or retrospective study?
So first of all, it is a retrospective study, and I haven't taken more than 65 years account because the patient more than in 65 years the bone is already osteoporotic, so we go for cementing technique, prefer for cementing technique only.
Okay. And how was your survival compared to in this case?
So the survival was not compared with the, I have compared my co-PG is doing in cemented, uncemented one. So I've compared with that and I got a comparable results. It was not better, but it was comparable.
Okay, very nice, sir.
Okay, one question. Though this is a retrospective study, is there any criteria or it is they had just doing only cementing on the both the side? They had not any criteria why they had chosen this cemented technique on both the side, because particularly acetabular side, most of the time it is better to do a non-cemented unless until it is indicated really. So is there any reason why you have chosen this? Though this is a retrospective, nothing is in your hand, but is there any reason why they had not done any, why they had done cemented technique only?
So it was like to compare either if the patients are not sometimes they are not able to afford the cementless one, so they have to do the cementing only, and that's why it was, as you said, that it was a retrospective, nothing in our hand why they decided.
Okay.
I mean, is there any criteria like DOR type A, B, C where you discuss like prefer cementing versus uncemented?
So in DOR, there are three types, like in which the calca to canal ratio is seen, and in A and B there is we prefer cementless one, and in DOR type C we prefer cemented one.
Okay.
So moderators, can we take the next presentation now?
Thank you.
Good evening, sir. Sir, is my screen visible?
Please share your screen.
Yeah, now it's visible. Start.
Yes. Good evening, sir. I am a third-year resident from KMC Manipal. I'll be presenting my paper on outcome analysis of ipsilateral intertrochanteric with the femur shaft fracture, which has been fixed with a single implant. So ipsilateral intertrochanteric with femur shaft fracture, it is an uncommon injury. It is commonly seen as a part of a polytrauma. It's commonly present in young patients, usually due to a high-velocity injury, which can either be a road traffic accident or a fall from height. The treatment of these complex femur fractures remain a challenge for the surgeons, as it is associated with complications like non-union, malalignment, and shortening. There are different techniques which have been developed to manage these fractures. It can either be including multiple implants, which can include a DHS fixation along with a plate, or DHS fixation along with a retrograde nail, or either it can be a single implant like a cephalomedullary nail. No consensus exists regarding the optimal treatment of these complex femur fractures. This was a previous article which showed which had a study which showed similar outcomes in both double and single implant fixation, with the decreased intraoperative bleeding, decreased soft tissue injury, and decreased and biological fixation of both fractures in a cephalomedullary nail. Another paper published in 2020 showed fixation of these complex femur fractures with a cephalomedullary nail was advantageous, as it allowed a biological healing of both fractures in a single surgery, and it also showed good surgical outcomes. So coming to materials and methods, present study is a retrospective observational study for a period of 10 years from January 2010 to July 2019. The exclusion criteria included prior history of trauma to the same leg, patients on immunosuppressants, a femur shaft fracture which was operated elsewhere, psychiatrically moribund patients, and blood dyscrasias. Methodology. So X-rays taken for my radiological assessment were X-ray pelvis with both its translateral view of the hip and femur full length AP lateral. Radiologically, patients are assessed immediately post-operatively and at routine follow-ups, which are at 6 weeks, 3 months, 6 months, and 1 year. The post-op parameters that were used were the number of lap screws used in the cephalomedullary nail, the tip apex distance, and the fracture fixation in the varus or valgus position. Complications like malunion, non-union, malalignment were assessed. Need for additional procedures were noted, and accordingly, procedures were done. At routine follow-ups, radiological parameters that were seen were fracture union, which meant bridging callus in 3 cortices on orthogonal views. At 1 year follow-up, patients were asked a questionnaire regarding quality of life using modified Harris hip score on telephonic conversation. Patients were also asked regarding their ability to sit cross-legged and squat according to Indian culture. All were also questioned regarding hip or knee pain. Coming to results, so this present study includes 36 patients with ipsilateral intertrochanteric with femur shaft fractures. Out of these 36 patients, 35 are men, 1 is woman. Mean age of presentation was 42.9 years. 34 of the patients had injury due to a road traffic accident. 2 patients had a fall from height. All intertrochanteric fractures were type 1 stable, Boyden-Griffin type 2 fractures. All IT fractures were closed fractures. Out of 36, 28 femur shaft fractures were closed while 8 were open. Closed femur shaft fractures were classified as per Rehnquist-Hansen classification. Open femur fractures were classified as per Gustello-Anderson classification. So mean time from accident to definitive surgery was 4 days. Out of these 36 patients, 3 patients underwent provisional external fixator application. 1 patient had an open type 1 femur shaft and he underwent definitive nailing after 3 days. Second patient had a closed type 2 femur shaft along with open type 1 prox tibia fracture, that was ipsilateral. He underwent definitive nailing after 3 days. Third patient had a head injury and nailing was done 18 days after provisional external fixator application. 23 of these patients had 33 associated injuries. This is case number 6 who had an open type 1 femur shaft fracture. He underwent definitive nailing 3 days after X-fix application. 4 patients were comorbid. So 4 single screw constructs were used while 32 were double screw constructs. The mean tip apex distance of single screw constructs was 28.5 mm. The mean tip apex distance for double screw constructs was 23.56 mm. In double screw constructs, we used an inferior screw for calculating the tip apex distance. The double screw constructs had a relatively better tip apex distance than single screw constructs in this study. So the neck shaft angle of opposite side femur was taken as the standard angle for neck shaft measurement. Post-op neck shaft angle was assessed and compared with the pre-op neck shaft angle of the other side. So 16 fractures were fixed in 0 to 5 degree of varus, while 15 patients neck shaft angle was in 0 to 5 degree of valgus. 3 patients had more than 5 degree of varus, while 2 patients had more than 5 degree of valgus in this study. So mean time of union of IT fracture was 12 weeks, 12.1 plus minus 8 weeks, while mean time of union of femur shaft fracture was 21.9 weeks. However, one femur shaft union had 156 weeks, which was an outlier. Removing that, mean time of union for remaining femur shaft fractures was 18.4 weeks. So in 5 cases, union of femur shaft was delayed, but only 2 required additional procedures. 1 patient required dynamization after 8 months and had femur shaft union at 13 months. Another patient required bone grafting and had a distal screw back out as well. And union happened 1 year following bone grafting, total 3 years after the initial nailing. So this is case number 13 of femur shaft non-union. After 1 year, we can see that the fracture has not united, following which bone grafting was done. We can see that fracture is getting united after 1 year after bone grafting. Functional assessment was done using modified Harris hip score. The mean modified Harris hip score was 88.39. All patients had excellent or good outcomes at the last follow-up. So conclusion, the cephalomedullary nail showed good radiological and functional outcome in the study with very few complications. However, open fractures comminution and displacement of the fracture site increases the time of union of femur shaft fracture. Managing the femur shaft fracture correctly is the key in managing these complex femur fractures. The advantages of these type of a cephalomedial nail is simultaneous close fixation of both fractures with biological healing at both fractures, and its load sharing property also allows early weight bearing. Thank you, sir.
Very good presentation, Dr. Abhinav.
Yes, sir.
I have never seen many cases of these intertrochanteric along with shaft femur. I have seen neck femur with shaft femur, but hardly seen any cases with this.
Yes, sir.
Abhinav, I'd like to ask one question.
Yes, sir.
What technique you had used to reduce the trochanteric fracture when there is ipsilateral shaft fracture?
Yes, sir. First we'll attempt a closed reduction, sir. Then the technique used was putting shank spin from the trochanter into the head and trying to provisionally reduce it. And
No. How you had checked the rotation? Normally, you have to reduce it by internal rotation, but if you are rotating, then the proximal fragment is free. It is something like segmental. Proximal fragment, whatever rotation you do, you will not be able to achieve any rotational movement on the proximal fragment, and then it cannot be aligned with the trochanter. So what is the way you had tried to, the way you had reduced that?
Yes, our sir put a shank screw in the head and then secured it with the help of a AO clamp, sir. And the femur shaft fracture, he has similarly used a shank spin or a bone hook, following which after both reductions have come, only has he entered the nail.
Second question, Abhinav, can you hear me?
Yeah, sir.
The second question, that all those compound injury, you did final fixation after 3 days. Is there any reason behind it?
Sir, 3 patients underwent external fixator application. But because, sir, they were type 2, sir, so they required debridement initially. And after 3 days, the patient underwent definitive nailing.
No, as per the theoretical teaching, after 3 days and type 2 injuries are treated as infected cases, and you are doing interlocking nail, a proximal femoral nail in such cases. What was the outcome? Did you face any delayed union because of infection or something?
Sir, no, sir. Actually, one patient in which had an open proximal tibia underwent non-union. One of the patients. He had an open proximal tibia fracture, sir.
Okay.
But the open femur shaft fracture underwent union, sir.
As per the treatment protocol, all these are considered infected after 3 days. So doing internal fixation is contraindicated as per the standard teaching protocol. But you did fixation and resulted in reasonable good result. Chalo, that's good.
Okay.
Thank you, sir. Thank you for the presentation. Now, can we invite the third? Can we invite the third speaker now, please?
Anmol Arpan Anand.
Good evening, sir.
Okay.
Sir, my screen is visible, sir.
Yes, sir, it's visible. Please make it full screen.
Okay, sir. Okay. Good evening to all of you, sir. My paper presentation is PRP used in orthopedics. Myself, Dr. Anmol Arpan, third year PhD students from Department of Orthopedics. Introductions, PRP is a platelet-rich plasma. It is common treatment for many orthopedic conditions like tennis elbow, golfer's elbow, or tendinopathies, and better tendinopathies, ventral fasciitis, and osteoarthritis, many conditions. And PRP is safe to use. It is autologous blood product. At present, various kits are available for preparing PRP, but there is very difficulties arriving for preparing patient for the orthopedicians because of availability of the cost. Aim of our study is to develop a safe and economic method to prepare PRP, taking proper aseptic and sterile manner that can be used for orthopedic OPD procedures. And material methods. 100 patients of tendinopathies were selected on OPD basis in our Department of Orthopedics in GRMC Goel for PRP treatments. And PRP preparation was done by double level centrifugation techniques using aseptic techniques, and appropriate blood volume of around 40 ml of venous blood is drawn and it is mixed with anticoagulant around 2 ml of citrus dextrose, and blood was divided into 8.5 ml in syringes. And then first centrifugation was done for 10 minutes and 1200 revolution per minute, result in suppression of whole blood into 3 layers: top layer containing the plasma, middle layer containing the buffy coats, and bottom layer containing RBC masses. And using the tri-way, we are separating the plasma and buffy coat to another syringes in a sterile manner and transferring. We stop when we reach the RBC layer or just 1 to 2 mm of that layers. Then second centrifugation was performed at 2400 revolutions per minute for 12 minutes. After centrifugation, there was visible supernatant plasma in the top and platelet mass at the bottom. And using the tri-way, we are discarding the supernatant and we are collecting the bottom, that is platelet-rich plasma. And same procedure was performed on other syringes. And at last, we are getting around 2 to 3 ml PRP, and which is injected directly over the most tenderness point using 20 gauge needles. And immediately after the injection, patient was kept in supine position, and strengthening exercise was initiated after 2 days afterwards. And what is basically PRP is? PRP is utilizing the growth factor content of the plasma to aid in healing of musculoskeletal tissues, and predominantly tendon, ligament, and muscle injuries. And it contains high concentration of growth factor, which deposit locally in area of injuries, it having anabolic effect that enhances and supports healing. For the methods of using PRP, we are giving around 2 to 3 injections every 4 to 7 days, and there is interaction between steroids and alpha granules. And we should avoid giving lidocaine along with the PRP because it deactivates the growth factor present in the PRP and is benefiting chronic cases. And for the PRP activation, exogenously activated by thrombin, calcium chloride, and mechanical trauma. And collagen is a natural activator of PRP. Hence, when we are giving the PRP in soft tissue injuries, we does not need to be exogenously activated. After activation, there is secretion of growth factor within 10 minutes, and more than 95% of pre-synthesized growth factors secreted within 1 minute of giving the PRP. And the working definition of PRP is around 10 lakh of platelets per ml in 5 ml of PRP. There is 2 methods we have seen. First is PRP methods, in which whole blood is obtained in acid-sided dextrose methods. First centrifugation was performed by soft spin, and second centrifugation is performed as hard spin. And lower third contains the platelet-rich plasma, and upper third is platelet-poor plasma. At bottom of the two, platelet pellets are found, which is collected for PRP injection. Second method is buffy coat methods. Here, whole blood is stored around 20 to 24 degrees for centrifugations. Here, after centrifugation, there is 3 layers formed. Top layer containing the platelet poor plasma, middle layer containing the platelet and WBC, and bottom layer containing the RBC. We are discarding the supernatant plasma for plasma and transferring the buffy coat to another sterile tubes. And this buffy coat is centrifuged at low speed, or we are using the leukocyte filtration to get the PRP. Regarding the anticoagulants, anticoagulants which preserve the function of the platelets and its morphology is recommended. Most of the authors are not recommending EDTA because it can damage the platelet. Anticoagulant we are recommended are citrate and sodium. Regarding the safety of PRP being an autologous preparation, PRP is devoid of any serious side effects. However, local injection reactions like pain and secondary infection can occur, which can be avoided with proper precautions. There is no risk of transmission of infection like hepatitis B, C, or HIV. PRP application techniques, we are giving around 2 to 3 cc of PRP by Prp techniques, average dose delivering around 3.3 billion of platelet per patients. There is corticoid injection. Regarding the comparison with corticosteroid injections provide rapid therapeutic effect compared to relatively slower but longer term effect of PRP. These are sites we are commonly using the PRPs. We are commonly using for ankle and foots like plantar fasciitis, Acl Tendinopathies, for knee like osteoarthritis of these, for elbow like lateral epicondylitis and medial epicondylitis. Basically, it's healing the injuries because it stimulates the growth factor responsible for almost all repair processes that naturally occur in body. Additionally, it attracts the stem cells, that is another natural healing element responsible for rebuilding damaged tissue. Consequently, new tissue is formed and healing occurs. Result, PRP is safe, economic, and aseptic procedure. It is peri-limiting tendinopathies. We are achieving batch score of around 1 in majority of the cases. Subsequent follow-ups. These are some of my references, sir. Thank you, sir.
Dr. Anmol?
Yes, sir.
Nice presentation. There's a question. Have you ever tried this PRP injection in complete cuff tears? Complete rotator cuff injuries?
No, sir. Not complete rotator tears.
So partial tears you use this?
Yes, sir. Yes, sir.
So whether that is the articular sided tear or the subacromial sided tear, have you a classification about which sided tear or any partial tear you will use it?
Sir, most time use a partial tear, sir, not complete, sir.
Partial tear, there are two types. One is articular side, the other is the subacromial side. So either of them you use it.
Yes, sir. Yes, sir.
Dr. Arpan,
Yes, sir.
nice presentation. The only question you had not mentioned that in what are the criteria how you take the platelet from the patients, means what are the quality the patient should have, whether the platelet count, whether the patient is on NSAID, whether the patient is on any anticoagulants or not. Have you kept this in your mind when you are
Yes,
taking
sir.
this platelet?
Yes, sir.
You had not mentioned in your this. What are the criteria on basis of which you had choose the patient to take the platelet-rich plasma?
Yes, sir. Unless
So
and
what is
until
the
patient,
criteria?
yes, sir. Unless and until patient is having normal platelet count and is not having anticoagulant therapy, you are taking the samples only.
Any criteria regarding the anticoagulant, the patients on ecosprin or NSAIDs?
No, sir. We are not taking or not patients, sir. Okay. Thank you, sir.
So can now we take the another speaker, Dr. Sajal. Are you ready with your slides?
Okay, hum le aayenge.
Thank you, Dr. Anmol, for nice presentation.
Thank you, sir.
Now,
Good evening,
Sajal,
sir.
yeah.
Is my screen visible?
Yes. Go ahead.
Good evening to all the respected faculty members. My name is Dr. Sajal Ahirkar. I'm a third year postgraduate resident in Sri Aurobindo Medical College and Postgraduate Institute, Indore. The topic of my presentation is efficacy of percutaneous plantar fascia release before initiating the pauncity management of neglected clubfoot. The clubfoot deformity is one of the most common congenital deformity leading to locomotor disability in the developing countries, especially in India. The neglected clubfoot, however, is one in which there has been no initial treatment or perhaps very inadequate and incomplete initial treatment. The obstacles of poverty, lack of awareness, and lack of appropriate medical resources and inaccessible location means that the treatment is either not initiated or incompletely performed. So there is a very little literature available for the management of these neglected clubfoot. So deciding how to manage and treat these children therefore becomes a significant challenge. The aim is to study the efficacy of percutaneous plantar fascia release before initiating the pauncity management of neglected clubfoot. My objectives are clinical evaluation using Pirani score, functional evaluation using the FRS scoring system of lavage and pauncity, effectiveness in terms of number of casts required for complete correction of the deformity, and complications, if any. So in the first image, we can see the Pirani scoring system. It is divided into 6 components, and in that 6 components, 0 is being good and 1 is being worst. First is curved lateral border, then medial crease, then lateral head of talus, posterior crease, rigidity of equinus, and empty heel. In the second image, we can see the functional rating system of lavage and pauncity. It is divided into 10 components: ankle dorsiflexion, fascial movement, the subtalar joint movement, position of heel when standing, appearance of forefoot, the gait, the talocalcaneal index and talofirst metatarsal index, shoes type, functional limitation, pain, and satisfaction of the patient. In the patient selection, the inclusion criteria includes the age between 2 to 8 years, the neglected clubfoot patient who have received no or minimal treatment till 2 years of age. In the exclusion criteria, age less than 2 and more than 8 years, and the patients who have undergone prior surgical management other than tendo-Acl sternotomy. Example: posterior middle soft tissue release, complete subtalar release, posterior release, and tibialis anterior transfer. My procedure protocol. First, the percutaneous plantar fascia release is done before initiating the first casting. The first cast is then applied in supination and abduction. Subsequent casts will be applied in maximum abduction at weekly interval till minimum of 30 to 50 degree of abduction is achieved. After this, percutaneous sternotomy will be done to correct the equinus deformity. If 30 to 50 degree of abduction and 10 degree of dorsiflexion is achieved after sternotomy, a final cast will be given in maximum corrected position for 3 weeks. If amount of dorsiflexion is less than 10 degree, then the cast will be changed at weekly interval post sternotomy also till 10 degree of dorsiflexion is achieved. And the final cast will be given for 3 weeks. Patient then will be given foot abduction brace. which she will wear 23 hours a day for first 3 months, then night sprints for 4 years. In the patient in which no improvement has been found after 4 hours are considered as failures and they are advised surgery. Patient will be followed up at monthly interval till 6 months post sternotomy, and clinical evaluation using the Pirani score and the functional evaluation using FRS will be noted at the final follow-up. Procedure protocol. In the first image, we can see tight plantar fascia. In the second image, we can see its percutaneous release. This is a case of a 6-year-old male with left CTV. Here we can see the typical deformities of clubfoot equinus, varus, and adductors along with its X-ray. It is the final follow-up after 6 months. Typically, in this case, we required 6 hours for the complete correction. The deformities have been corrected and the X-ray. My results and discussion. This is a stack diagram showing association between the age and number of casts applied in the first bar of 2 to 4 years of age. Maximum number of patients, that means 61.5% of patients required only 5 casts for the correction, whereas in the bar 2, between the 5 to 8 years of the age, maximum number of patients required 6 to 7 casts for the complete correction. So we can understand by this that as the age increases, the number of casts for the requirement of the required for the correction of deformity also increases. This is a bar diagram showing mean number of casts required for correction and the comparison with different studies. And in our study, least number of mean casts are required for the complete correction of the deformity. This chart shows the comparison of our study with other studies with the mean number of casts and the mean Pirani score. Thing to note here is, even after the highest mean Pirani score in our study, that tends to be 5.87, the mean number of casts required for the complete correction of deformity is least, that is 5.83. Even our FRS scoring system, according to our FRS scoring system, maximum, that is 90% of patients had excellent to good outcome. In the conclusion, in the developing countries, especially like India, lack of awareness, ignorance, poverty is the root cause of the negligence. The biggest challenges faced are regular follow-ups and compliance to the treatment. We have achieved affirmative results in terms of duration of the study and the number of casts needed to completely correct the deformity. This treatment strategy have made it possible to decrease the number of visits to the hospital and lesser loss of work days to the daily wages workers, so that their parents, which directly contributes to the reassurance of the timely follow-ups and our good compliance. These are my references. Thank you so much.
Now the session is open for questions.
Hello.
Yes, sir.
So what do you think that after releasing this plantar fascia, how you are able to achieve a good correction? How it is benefiting to correct the problem of this neglected CTV?
Sir, I think that because of the plantar fascia release, the cavus deformity is very early corrected. Might be in some cases, more casts were required just to correct the cavus deformity. So that increases the total number of casts and the duration of the treatment. So I think this is this method is beneficial.
Okay.
So should we proceed for the next speaker?
Thank you, sir.
Thank you, Dr. Sajal. And now, Dr. M. Gopal Rao, are you ready? Okay,
Yes, sir. Good afternoon, sir. Sir, are my slides visible, sir?
Yeah.
Yes, sir. Thank you so much, sir. Thank you so much for the opportunity to present, sir. Very good afternoon to all.
Okay, it's okay. Yeah, it's good.
Very good afternoon to respective consultants and myself, Dr. M. Gopal Rao, PG resident from the Department of Orthopaedics, GMC Bhopal. My topic is to assess the outcome of proximal femoral nail and proximal femoral nail anti-rotation 2 in intertrochanteric fractures. Introduction. The incidence of intertrochanteric fractures has been growing as a result of the longer life expectancy owing to the better quality of the life, and the treatment is a big challenge.
mainly because of the severe osteoporosis and the medical disorders and the risk factors associated with the surgery and the anesthesia. So the main focus of the research in these fractures is to reduce the implant failure and the cutout of the femoral head and neck fixation components. And the main aim of operating these fractures is early mobilization and better functional outcome of the patient. Therefore, choosing the optimal fixation method and instrument is essential for the positive clinical outcome. Among the numerous implants, PFN has been reported for the years as a suitable implant for the treatment of intertrochanteric fractures in the elderly patients. However, studies have reported several complications like cutout and Z effect and varus collapse. So in 2009, the AO has introduced PFN-A2, particularly for the Asian patients. The change to the helical blade of PFN-A2 was reduced the cutout and eliminated the occurrence of Z-effect mode of failure of the old PFN. And this has been supported by several biomechanical studies also. These are the X-rays showing the screw back out in the first X-ray and Z-effect mode of failure of PFN. Inclusion criteria of age more than 50 years and intertrochanteric fractures, Boyd Griffith type 2, 3, and 4, and closed fractures and osteoporotic fractures. And exclusion criteria, compound and pathological fractures are excluded, and intertrochanteric fracture Boyd Griffith type 1 is excluded, and the patients with active infections and septic arthritis, and who have history of surgery or the fracture over the same hip, and patients with the deformity over the proximal femur were excluded from the study. And material and methods, it's a prospective study, and total 20 patients who were operated in the GMC Bhopal between the years 2019 and 2021 are included with a minimum follow-up of 6 months. We have evaluated the preoperatively patient with the age, sex, mode of injury and fracture classification and preoperative mobility status and comorbidities. And the functional outcome was assessed using modified Harris chip score. And the operative technique, patients were operated on traction table with the closed or minimal open reduction. Closed reduction was carried through longitudinal traction and manipulation under CAM guidance. In case of failed reductions, Steinman pin was used, and in some cases we use reduction forceps. And in PFN, the entry was made directly over the tip of the greater trochanter, and in PFN-A2, the entry was made through the medial border of the tip of the GT. And lag screw on the helical blade was passed in central position and infero central position in neck and head. And both shorter and longer versions of the nails were used. And observation, mean age in PFN-A2 was 60 plus or minus 6.7 years, and in PFN it was 58.2 years. And in both groups, females were predominant, and type 2 Boyd Griffin was more common in both groups. Duration of surgery, in PFN-A2 it was 52.5 minutes, and in PFN it was 67.5 minutes. And blood loss was 93.9 ml in PFN-A2 and 148 ml in PFN. And union was 12.4 weeks in PFN-A2 and 15.6 weeks in PFN group. And we have encountered two complications, which was screw backout and thigh pain. Thigh pain was observed in 6 patients in PFN group, and screw backout was observed in 2 patients of PFN group and 1 patient in PFN-A2 group. As I said, mean age in the study population was 60 years in PFN-A2 and 58.2 in PFN group. There is female predominance in both the groups, and type 2 was involved in 75% of the patients. And among the 10 cases in PFN-A2 group, the average duration of surgery was 52.5, and among the PFN it was 67.5 minutes. And as I said, intraoperative blood loss, it was 93.9 ml, and in PFN it was 148.5 ml. And the average time for union, it was 12.4 weeks in PFN-A2 group and 15.6 weeks in PFN group. The functional assessment, patients treated with PFN-A2 showed better results compared to the PFN group. At final follow-up, the Harris score in PFN-A2 treated patients, 4 patients had excellent outcome and 5 patients had good outcome and only 1 patient had fair outcome. And among the patients treated with PFN, 2 patients had excellent outcome and 3 patients had good outcome and 5 patients have fair outcome. And complications was higher in PFN group compared to PFN-A2 group. Both functional and the radiological parameters at 3 months, 6 months, and at final follow-up respectively showed statistical significance better in PFN-A2 group than PFN group. Discussion. This was one of the patient pre-op X-ray who was treated with PFN-A2. This was intraoperative C-arm pictures showing a PFN-A2 fixation. This was 6 months follow-up X-ray with clinical pic showing good functional outcome. This was case number 3. One of the patient treated with PFN-A2 showing pre-operative X-ray and follow-up X-ray with good clinical outcome. This was one of the patient treated with PFN, immediate intra-op X-ray. And this was at 4 weeks with clinical peak. At 4 weeks, showing good skin condition. And 3 months with good functional ROM and good functional outcome. Some of the studies in this Ram Avatar et al. They have studied clinical evaluation of PFN-A2 in unstable paratrochanteric fractures. In their study, they concluded that PFN-A2 is an attractive and suitable implant for unstable trochanteric fractures. In another study, they also said better results in terms of preoperative morbidity. These are also the studies who have supported my paper. And in conclusion, PFN-A2 gives better results than PFN in unstable IT fractures in terms of blood loss during surgery and the duration of surgery and post-operative complications. But a longer follow-up with more patients is required to substantiate this statement. And the limitations of my study, small sample size and shorter duration of follow-up, and the surgeries performed by different surgeons, and mostly patient selection with a proper pre-op planning are required for getting better results. Thank you so much.
Dr. Gopal.
Yes, sir. Good afternoon, sir.
Good afternoon. There are 2 questions. One, you had said that in PFN-A2, the union rate is 12 weeks and in the other group is 15 weeks. How this implant has improved the union rate in terms of duration. Second is how you had said that you had used long as well as short nail. How you had decided that in which case you will do long nail and in which case you will do the short nail.
Yes, sir. Mostly we have decided intraoperatively, sir, whether to use short nail or long nail, sir.
What basis?
Yes, sir. In fractures which are 4-part and which are high, in those cases we have used long nails, sir, mostly.
Okay. And what about the union rate?
Union, sir, implant doesn't have any direct effect on the union in our study, but what we observed in our study is those patients who are operated on PFN-A2 have showed early union compared to PFN group, sir. But implant doesn't have any direct role on the union, sir.
Okay.
So now we can have the last speaker.
One more question. Dr. Gopal, Did you
Yes, sir.
randomize the patients, and how?
Yes, sir. We have randomized, sir. We don't. We have randomized only, sir, patients.
How?
So, sir. Sir. We just whoever admitted in the department, we have decided there is no selection criteria. We have put to keep particular patient on PFN-A2 and PFN, sir. We just decided randomly only, sir. We don't have any
How did you decide?
criteria, sir.
Then how did you randomize? The question is still unanswered. How did you decide
sir,
that?
Actually, sir, just like random sample, sir, we just we don't have any selection criteria. Particularly for PFN-A2, we have to keep this implant like this, sir. We just selected on random.
Okay, Chap. Now we can take the next speaker now.
Hello, good evening, sir. Am I audible, sir?
Yes, you're audible.
Yes, sir. And my screen is visible, sir? Is my screen visible, sir?
That is visible.
Yeah, you can proceed.
Okay. A very hearty good evening to one and all present here. My name is Dr. Shitish Srivastava, and I'll be presenting my presentation on the use of high anterolateral portal in ACL reconstruction. So, as we know, ACL is the most commonly injured ligament in the knee joint. The symptoms of an ACL injury are knee instability, pain, and a decrease in joint function. And in symptomatic young individuals, in modern times, arthroscopic ACL reconstruction is considered as a gold standard treatment using the hamstring tendon graft. So, the conventional anterolateral portal that is used in knee arthroscopy makes the evaluation of the posterior aspect of the lateral intercondylar notch challenging and further complicates the identification of tibial footprint. Also, for better vision during the femoral tunnel placement, the Hoffa's fat pad needs to be shaved off while using the conventional anterolateral portal. So, in this study, we have used a high anterolateral portal located 1 centimeter above the standard portal, which may present a solution to this. The aim of our study was to evaluate the functional outcome of single bundle ACL reconstruction with quadruple hamstring graft using the high anterolateral portal in ACL deficient knees. These objectives were met by comparing the pre and post-operative range of functional activity using the Lishom knee score and the IKDC knee score, and to study any complications arising out of it. So, this was a prospective study which was conducted in LLRM Medical College, Meerut, for a period of 2.5 years. And after proper evaluation and PAC checkup, the patients were operated using this modified two-portal technique. Endo button and bioabsorbable screw were used as fixation devices, and no graft augmentation was done. So our inclusion criteria was that we chose patients between an age of 20 to 50 years. The patients were clinically and radiologically confirmed of having ACL insufficiency. They need to have no history of any previous surgery in knee. They needed to have a normal contralateral knee, and we accepted any medial or lateral meniscus injury or grade 1 or grade 2 LCL and MCL injuries. For our exclusion criteria, we excluded all asymptomatic individuals or people that had systemic diseases that affected their pre-anesthetic fitness, any local skin infection, any associated PCL injury, patients with osteoarthritic knee, and any associated grade 3 or grade 4 LCL MCL injuries. So the ACL reconstruction was performed using this modified two-portal technique, where the high anterolateral was placed at the level of inferior pole of patella 1 centimeter higher to the conventional one, which permitted a broader view of the patellofemoral, medial, and lateral compartments, and also avoided penetration of the Hoffa's fat pad. The antropedial portal, which is the working portal, was kept the same as a conventional portal. So the high anterolateral allows a bigger viewing field for evaluating the anatomical tibial footprint, whereas the use of the two portals together allowed for a more optimized placement of the femoral canal. Here we have a snapshot of intra-op, where we can see where the conventional anterolateral portal is and the high anterolateral portal has been placed about 1 centimeter away, just at the level of the inferior pole of patella. The anteromedial portal is just as it is used in conventional technique, and also there is the incision has been shown from where we harvested the graft. This is in brief the presentation where showing the basic technique where we give the incision for graft harvest, and there is no difference in this from any conventional technique. So the post-operative care and rehabilitation was also as we do after conventional technique, where we place the patient in immobilization in static knee brace, and quadriceps strengthening exercises are started from day one. Intravenous antibiotics were given at our center for 5 days. Patient was allowed to bear weight in brace from second week. Sutures were removed on the 12th day, and patient was allowed to return to his sporting activities by 6 months. So this is one case illustration which I have included of a 24-year-old male who showed ACL injury, and this was his pre-operative range of motion, and this was after the surgery was performed. And at 3 months follow-up, you can see that he had achieved quite a decent range of motion, and at 6 months, so he was able to comfortably squat, walk up stairs, return to his sporting activities, and had no pain whatsoever. So our observations, we studied a total of 33 patients with ACL injury, out of which 28 were male and 5 were females, and they were followed up for more than 2 years on an average. Most patients, they belong to an age group of 21 to 35 years, that is around 31.8%, and the mean age of our patients was 29.8. The most common mode of injury was playing sports, followed by self-fall, and the most common presenting symptom was instability. So this was our pre-operative Lishon scores, which was mainly in the range of fair to poor, and the average pre-op Lishon score was around 70.27, which is fair. The post-op Lishon score, as you can see, of almost 2/3 patient was excellent, and 30% of the patient had good post-op Lishon scores. The average post-op Lishon score of our study was 90.9, which is excellent. Also, the IKDC subjective score, the pre-op was 62 and post-op was 88, which showed an improvement of around 25.7 points, which is 41%, which is quite a significant difference. So the average duration of our study was around 14 months with a minimum follow-up period of 9 months, which is, if we compare them with all the existing studies, our duration was much shorter than them. Also, the high anterolateral portal instead of conventional portal allowed us to effectively identify the tibial growth fit. And there's a study by Sanjay et al., which shows also the importance of Hoffa's fat pad in acting as a modulator of inflammation in knee and also in helping the neovascularization of ACL graft. So preservation of Hoffa's fat can improve the long-term knee kinematics. Also, none of the patients had any major complications. We show that high anterolateral portal is not associated with any added risk as compared to anterolateral portal. And the functional outcome of our patients, even though of short duration, was comparable and in some cases even better than the existing studies on ACL reconstruction. So in conclusion, I would say that use of high anterolateral portal allows a better identification of tibial footprint with more accurate tibial tunnel placement and preserves Hoffa's fat pad, and individualizing anatomical ACL reconstruction according to patient's soft tissue and bony anatomy is key to long-term success of any ACL reconstruction, and the use of high anterolateral portal could be a very simple yet effective option in achieving this. The limitation of our study was probably a small sample size and a shorter follow-up period, and the results are based more on a subjective assessment rather than an objective parameter. Thank you.
Thank you, Dr. Kshitij. So there are a few questions. First is,
yes, sir.
It is definitely of help putting lateral portal high to avoid the fat pad.
Yes, sir.
But did you ever face any problem in looking at the posterior horn if your portal is too high? Like suppose you are making it 1 centimeter high, and the real problem in these arthroscopic cases is looking to the posterior horn of the meniscus. Did you ever find any problem looking to the posterior part of the knee?
Yes, sir.
Dealing with it?
Yes, sir. The only reason why sometimes people say that the portal should not be placed too high is that the diagnostic arthroscopy part becomes a little difficult. But we found that in most cases, we were able to evaluate with after manipulation of the knee and a little further time than that it usually takes with conventional portal, we were able to reach the posterior horn. In most cases, we performed an adequate diagnostic ultrasound.
Yeah, because in meniscal tears, we try to keep this lateral, because this is the only portal which is blind. We try to keep this portal down in the meniscal tear cases because we have to look into the posterior horn. Anyway,
Yes,
another thing is you have excluded grade 3 and 4 LCL MCL injuries and included grade 1 and 2 MCL injuries. Any specific reason you have excluded?
Yes, sir. Because in studies it has been shown that grade 3 and grade 4 MCL and NCL injuries can have long-term effect on functional outcome, which could have been a bias in this case. That's why we have not included those injuries, because they would have affected the functional outcome despite of us having performed an adequate ACL reconstruction, sir.
Okay, thank you.
Thank you everybody. Thank you respected chairpersons, Dr. Arya sir, Dr. Vinod sir. And yes sir.
Just allow me to say somewhat to all the delegates, all the speakers.
Yes sir, please, you are most welcome sir, please.
I think it is a first presentation for all these speakers. There is something which I would like to suggest to all of them. None of them except one had shared the slide with their guide name on. I suppose the studies are part of their thesis dissertation, and none of them has mentioned their guide name. College name was too small, and very few have elaborated the references and bibliography. And finally, from ethical point of view, please don't share faces of patients without their permission or without written approval. Otherwise, face should be blurred. I think these are small things which will take you a long way and will help you in later presentation always.
So this is a very important aspect of any presentation or any thesis or any work, sir. I think every postgraduate and every researcher should take care of it. Very nice suggestion, sir.
Thank you.
Any other suggestion from our senior members, Dr. Vinod, sir?
I think it's a very well organized and everything goes very well. I agree with the Professor Arya's suggestion that the students should take care of these things, that they must mention under whose supervision and how the work was carrying actually, and limitation of the studies and any drawbacks of that particular study should also be equally highlighted. So I think otherwise everything is well, and congrats to all of you. Thank you.
Thank you, sir. Rajesh, sir?
Yeah. First of all, this is a flawless, there is no technical glitches, and it is very good presentation. Various topic has been covered. This is very good. And I think this is for the first time they are presenting their presentation, and they should pick up something for betterment of their slide presentation. There are various literature available how to make a effective PowerPoint. So they should go with that, and they should not use more than 8 to 10 lines. There are certain type of characters which they should not use. So they should come. This should be the part of the basic PG teaching training program. So I think for the first time they are presenting. It is good, and they had various type of studies are there. It's very good. I would like to congratulate to you and your whole team to make this program such a nice way, and it's a very good program.
Thank you, sir. Thank you.
Thank you, dear.
Thank you all the chairpersons and moderators. Thank you. We will switch over to our next session.
Session 2, Hall 1. I welcome our moderator, Dr. Arun Kapoor, Dr. Shivam Sinha, and Dr. Kaushal Agarwal. Dr. Arun Kapoor, sir, please take over.
Good evening, friends. Can you hear me?
Yes, sir, you are audible.
Good evening, sir.
I congratulate all of you from the Western Medical College. You're doing a great job. Wonderful going. Lovely teaching, good initiative, and very good going. I'll welcome my chairpersons, Dr. Amit Rastogi, Dr. Shivam Sinha, and Dr. Kaushal Agarwal, and my co-moderator, Dr. Ashwani Sadana. Is that right?
Sir,
are we all here?
Dr. K.D. Tripathi and Dr. S.C. Goel are also as chairperson. There's been a little updation of scientific program.
Updation. Okay.
Doctor. So, Dr. Amit Rastogi, sir, Dr. K.D. Tripathi, sir, and Dr. S.C. Goel, sir, are chairpersons. We welcome you all.
We welcome you all. Are we here? All of us present?
I'm here. Yeah, good evening, friends.
Welcome, Dr. Tripathi. Good to see you.
Good evening,
Thanks,
sir.
good evening.
Goel sir,
Dr. S.C. Goel sir.
such a senior member of IUA, and sir, we want some address from you. Just 1 minute before starting the session. Please, sir.
Last time when Dr. Najmul did this type of program, then I insisted in the meeting of UPOA that this must be perpetual. Every year we must do it. And I'm very happy that SN Medical College is doing it very well. And I'm sure it is going to be a great success.
Thank you, sir. Your background is very nice, sir.
Thank you. Thank you, sir. Now over to Arun, sir. Please.
As a first speaker, we'll be having Dr. Nishant. Are you ready, Nishant?
Dr. Sarthak Gupta is our first speaker.
Yes. I think I have the wrong list. I think I have the wrong list.
I will just update you, sir. Dr. Sarthak Gupta, evaluation of congenital talus equinovarus from JNMC Varda.
Okay.
So the presentation is of 8 minutes and 2 minutes for
6
discussion.
minutes.
6
minutes, sir. And 2 minutes for the discussion.
Right. So we'll be taking questions simultaneously.
Yes, sir.
Over to Dr. Sarthak Gupta for evaluation of congenital talus equinovarus by sonelastography.
Good evening, sir. Is my
you are audible and your slides are visible. Please continue.
Yes. Good evening, sir. Today, I, Dr. Sarthak Gupta, will be presenting my paper on evaluation of congenital talus equinovarus by sonoelastography. Congenital talus equinovarus, or clubfoot. It is a congenital deformity involving the ankle and the foot, with plantar flexion deformity at the ankle joint, inversion deformity at the subtalar joint, and adduction deformity in the forefoot. It is a most common musculoskeletal birth defect, with 1 in every 1,000 live births. It can be idiopathic, neurogenic, or syndromic, with idiopathic being the highest prevalence. It is a complex deformity which requires meticulous and dedicated efforts on both the parts of the parents and the orthopedic surgeon to attain optimal treatment. Was to study the changes in echogenicity of tendon substances in patients with CTEV by real-time sonoelastography. My objectives were to evaluate the severity score, the Pirani score, before and after the treatment of deformity, to evaluate the sonoelastographic properties, the strain ratio of tendon Achilles of the affected foot before and after the treatment, to clinically correlate the severity score and the Pirani scoring system. It is a prospective observational study which included total 30 club feet who were less than 2 years of age, who came under the inclusion criteria of being idiopathic, of any gender, unilateral or bilateral, treated or untreated club foot. Any neurogenic, syndromic, or traumatic club foot were excluded from my study if the patient had any surgery around the leg, or if the patient was suffering from any congenital limb deficiencies, he was also excluded. The equipment used was Hitachi Aloka S70 with a ultrasound probe of MSK line at 12 to 18 megahertz. This is an image showing an elastography being done. The left half of the image shows a normal USG image of the distal part of the leg, and the right half of the image shows an elastographic superimposed image with different color codings. The blue showing the hardest substance and the red showing the softest substance. We took into consideration 2 regions of interest. Region of interest 1, which was positioned on the tendon, and the region of interest 2, which was positioned on the bone. And this is how we calculated the strain ratio by the formula strain of the tendon ROI1 and upon strain of the bone ROI2. Strain ratio was calculated at 2 different locations, at the insertion of the Achilles tendon and 2 centimeters proximal to the insertion. On assessing the data, we found that there were total 16 males and 14 females in our study. There were a total number of 17 left foot CTEV and 13 right foot CTEV. Most of the patients came under the age group of 1 to 5 months. And on assessing the variability in strain ratio, we found that there was an increase in strain ratio after the serial casting. At the site of insertion, our strain ratio was 1.03 on presentation, and after the correction of deformity and completion of serial casting, it increased to 1.35.
And at 2 centimeter proximal to the insertion, our strain ratio on presentation was 1.11, and it increased to 1.39 after the correction of deformity. The mean Pirani score was 4.43. On correlating the two, we found that there was an inverse correlation between Pirani score and the strain ratio. Thus, we can conclude that as the Pirani score decreases, the strain ratio increases. In our study, the mean age of the patients was 6.23 months, with majority of them being male. There was an increase in strain ratio after serial casting, and it was statistically significant. The average Pirani score on presentation was 4.43, and there was an inverse correlation between the strain ratio and the Pirani score. Thus, we concluded that sternolastography is a simple, feasible, and easily reproducible technique to evaluate the mechanical properties of Achilles tendon present in children having clubfoot. Sonolastography can be an objective tool to evaluate and monitor the course of treatment. In our present study, a vital correlation has been noticed between real-time elastographic impressions and age, but no such influence of gender was noticed. This study will be going to be helpful tool for the future researchers on CTEV. These were my references. Thank you so much for the opportunity.
Very nice, lucid presentation. Dr. Sathak, any questions from the chair?
Yes, it was a very interesting study about sonolastography. But in what way this is going to influence our treatment protocol? Can Dr. Shivam, can Dr. Sathak tell us?
Yes, sir. Sir, first of all, as we all know that Pirani score is an observer-based scoring system, and it is prone to observer bias. So first of all, we need a definitive, objective, investigatory modality to assess the structures involved in our deformity. The second, by assessing the stiffness of the tendon, we can assess whether that particular patient will need tenotomy or not. Because most of the patients most of the surgeons go for excessive treatment and to overcorrect the deformity. Thus, we need to prevent that.
So what deformity you are talking of? For regarding the tendoachilles, what you evaluated, which score was the most prone to get affected?
Yes,
which score of the Pirani was most affected? And second thing, which deformity you are talking of? If you are talking about tendoachilles, then I think you are talking only of equinus.
Equinus, yes, sir. Because most of the time, most of the patients require Achilles tendon tenotomy for the final correction. But some patients, we have achieved only by casting the full correction of the deformity. Thus, by assessing the stiffness of the tendon by strain ratio, by doing elastography, we can assess whether that particular patient will need tenotomy or not, or whether that particular patient in future with further studies, whether it will go in relapse or not, based on the stiffness of the tendon.
Prior to tenotomy?
Yes, sir. Prior to tenotomy.
So that should be some kind of message in your conclusion. Yes, Rastogi, sir.
Okay, I just want to ask one question, Dr. Sarthak.
Yes, sir.
Please correct me if I am wrong. If your strain ratio is high, that means the tendon is more stiff.
No, sir. Strain in this, we have compared the strain. The harder the structure, the lesser the strain. Thus, as the deformity gets corrected, the tendon becomes supple. And as it gets supple, the strain will increase.
The strain ratio is high.
Yes, sir.
Then that means the tendon becomes more stiff.
Tendon becomes softer because we are comparing the strain with the bone.
Okay. The tendon becomes softer. How do you explain the fact? So, how do you explain the fact that as you keep on manipulating, the tendon becomes softer?
Yes, sir, because as the deformity, we are continuously stretching the tendon on each occasion. After every weekly casting, we are stretching the tendon and making it supple. Thus, it will lead to the correction of the deformity. And that's why we keep the cast for 1 week, and so that the tendon accommodates and deformity gets corrected.
Dr. Sarthak, I have a comment.
Yes,
so, okay. So, Sarthak, tell me something. In patients who needed tenotomy, what was the strain ratio?
Sir, in my particular study, we didn't assess patients who needed tenotomy. Our main aim was to assess the strain ratio, what happened to the strain ratio after serial casting. With further studies, we'll be able to assess whether they'll need tenotomy or not.
Okay, fine. Thank you.
For simplicity, Sarthak, can you tell me what are the indications for TA tenotomy in CTV?
Sir, first of all, after 4 to 5 casts, when the equinus deformity is not fully corrected, we go for Achilles tendon tenotomy to fully correct the deformity, and then we apply the final cast for the patient.
Okay, in my suggestion, you should change your topic, evaluation of TA tendon stiffness with elastography as an indication for TA tenotomy. I think that will be more informative. You're talking overall about CTV, so there are many other tendons who are under, who are stiff and difficult to manipulate. That will be my suggestion. I think chair can add to it.
Okay, sir.
And Dr. Sarthak.
Okay, I think.
Dr. Sarthak.
Yes, sir. Yes, sir.
Suppose you have done the tenotomy, and can you just predict that this patient is going to recur again the equinus deformity, because stiffness in these patients become quite more?
Definitely, sir. Definitely. With the help of a strain ratio, we will be able to assess the stiffness, and a stiffer tendon will be more prone to relapse than a softer tendon.
So, keeping with the time, I think we should move to the
I think
next
we are proceeding.
presentation.
We are getting onto our overshooting a time. We'll have Dr. Prakhar Maheshwari from the Himalayan Institute, Dehradun. I think he'll be speaking on plasma cell-rich osteomyelitis, a rare entity. I would also be wanting to hear that. Plasma cell-rich osteomyelitis. Can we have you?
Good evening. Good evening to the respected chairpersons, all my seniors and colleagues. I'll be presenting a case report on the topic plasma cell-rich osteomyelitis, a rare entity. So Gare first used the term sclerosing non-purulent osteomyelitis in the year 1893. So this plasma cell osteomyelitis is is characterized by localized plasma cells without the typical clinical features of infection, typically normal blood investigations, and radiologically it has been described as dense thickening of a bone without sequestrum formation. So we got an 11-year-old female in our OPD with the complaints of pain and swelling left shoulder and proximal arm since 1.5 months. These symptoms, these complaints were aggravated since 10 days. There is a history of trivial trauma present, and there is also a history of on and off low-grade fever since 2 months. So while examining the case, we found a diffuse circumferential swelling over the left shoulder and proximal arm, and there were no signs of soft tissue involvement, but there was a slight local rise of temperature and tenderness with an abnormal mobility at the neck of humerus. We also found bony irregularity at the diaphysis of the humerus, and the range of motion was extremely painful, while the distal neurovascular status was intact. On ordering X-rays, we found osteopenia and rarefaction at the metaphysio-diaphyseal region and the fracture of the surgical neck of humerus. We also found cortical irregularity noted in the mid shaft of humerus and lamellated periosteal gaction along with that. So these are the plane diagrams showing the left shoulder and arm. As you can see, there is a fracture of the neck of humerus with cortical irregularity, and we can also see a periosteal gaction in the diaphyseal region. So on ordering lab investigations, the total leukocyte count was within normal limits, and the differential leukocyte count is as shown on the screen, while the ESR was of 17 mm/h. So we were stuck between the differential diagnosis of calling it either osteomyelitis or calling it an Ewing sarcoma. So we went ahead and did a core biopsy from the lesion, and we found and we sent the sample for histopathological examination, culture sensitivity, as well as a CB-NAT. So as you can see in the given slide, on light microscopy with hematoxin and eosin staining, we found many plasma cells having abundant basophilic cytoplasm, but there was no evidence of malignancy. So according to this, we made a provisional diagnosis of a plasma cell-rich lesion, still not narrowing it down to whether it is osteomyelitis or some kind of an Ewing sarcoma, because Ewing sarcoma also shows a abundance of small basophilic cells. So we went ahead and did an immunohistochemistry. So as you can see on the upper hand left corner image, it is a CD99 staining. So as you can see, there is an absence of a brown color on the upper left hand image. So it is negative for Ewing sarcoma. While on the upper hand right image, you can see there is a abundance of brown color in the slide, which is positive for CD138. So it signifies that it's a plasma cell rich lesion. On the CBNAT, the CBNAT was negative for Mycobacterium tuberculosis, while a culture was positive for Staphylococcus aureus. So we gave the patient a U-SLAB splintage for 6 weeks, prescribed antibiotics based on the culture sensitivity, and also gave non-steroidal anti-inflammatory drugs. At 6-week follow-up post-biopsy, fracture union was appreciated and splintage was continued. So this is an X-ray of the same patient, which is after our treatment. So as you can see, there is union in progress, but with a varus still. So so this kind of an osteomyelitis, according to literature, is a primary localized chronic hematogenous osteomyelitis with a clinically vague onset, and very scarce literature is available on this topic. This is supposed to occur when the body resistance is good and the virulence of organism is restricted, and happens usually in children and young adults. Most commonly, the metaphysis of the long bone is affected, and the male to female ratio is 3:2. While the clinical course is slow and inactive, and there may be some symptoms of cold and fever, especially associated with tonsillitis or sinusitis. So Reddy M. et al. In his case report showed atypical features, that is a diaphyseal involvement in some cases, and the sequestrum formation also. And typical radiological picture, as described in literature, is sclerotic in nature. While Exner described 3 distinctive zones on the basis of light microscopy, and we also found those 3 zones, distinctive zones, on our light microscopy slides. Culture positivity is only 8% of cases involving bones other than the mandible, and Staphylococcus aureus has been proved as a causative organism in many cases. So some authors have also described that we should use the term primary chronic osteomyelitis for this case. So in conclusion, whenever you have a diagnostic dilemma of this kind, go for a histopathology, as well as you can supplement it with the immunohistochemistry, and they are found to be the definitive tools in deciding what diagnosis we have to make. And this shows that there is an importance of biopsy before proceeding for treatment. Knowledge of this condition may yield in better outcomes and avoiding unnecessary investigations and procedures, while preventing an overly increased frequency of diagnosis of Ewing sarcoma. These are my references. Thank you.
Thank you, Dr. Prakhar. May I have questions from the chair?
Dr. Prakhar, to me, it looked like a typical osteomyelitis, which we see so many cases must have seen. So will you advise everybody to go for immunohistochemistry? It was a metaphyseal environment going through the diaphysis. It was not a pure diaphysis in the center. It was a metaphyseal environment, and it looked like a simple osteomyelitis. And treatment remains the same. Why you want to do immunohistochemistry in every patient?
Sir, actually, in this case, while we correlated the history as well as the radiological appearance, and we sent the biopsy for as culture as well as a histopathological examination, and it confused us because basically it involved diaphysis as well as the metaphysis, and presented with a fracture in the first case. We got small brown loose cells on the histopathological examination. So that was the point where we were in a dilemma, that either calling it a plain osteomyelitis because we found Staphylococcus aureus also, or because an abundance of plasma cells were found. So it may be a contamination of Staphylococcus aureus, and we might be looking at some other picture. So that on that basis, we went for immunohistochemistry after reading a lot of literature on this particular condition.
Any non-invasive investigation you could have taken?
Sir, in this case, we went for we had to make a definitive diagnosis. So we went for a biopsy, a core needle biopsy.
Or any other non-invasive investigation would have hinted better. Yes, Rastogi, sir.
Sir, very simple. I think what Professor Goel just now said, I think you got confused because you did too many investigations. What is the incidence of plasma cell infiltration in standard chronic osteomyelitis?
Sir, in standard chronic osteomyelitis, yes, we get a lot of plasma cells.
Right. Now, unfortunately, you did a core biopsy. So up till your third slide, you were okay. I mean, is it osteomyelitis or is it malignancy? What I would have done, looking at that X-ray picture, I would have said that 60% it is osteomyelitis, 40% might be a malignancy, and I would have gotten a final aspiration cytology. That's all I would have done. And
Thank
that
you, Dr. Rastogi. I think you can round up Dr. Rastogi instead of asking him, because we are running short of time. Yeah, you just give your expert comments.
That's so nice presentation, but I think the message I got from your this thing is that you should use your investigations judiciously.
I think well said. We have Ronak Saxena, Dr. Ronak Saxena, and he'll be speaking on the high tibia osteotomy opening wedge, unicompartmental osteoarthritis knee. I mean, Dr. Ronak.
Good evening, everyone. I would like to start my paper with on the topic of evaluation of outcome of medial open wedge high tibial osteotomy with Tomofix for unicompartmental osteoarthritis knee under the guidance of Dr. Navneet Badoni. High tibial osteotomy is an accepted surgical technique for the treatment of medial compartment arthrosis of the knee in younger patients. Selection of the appropriate patient's extensive pre-operative planning and accurate surgical technique are essential for successful outcome. The biomechanical principle of high tibial osteotomy is to distribute the weight-bearing forces from the worn medial compartment across the lateral compartment, thereby relieves pain and slows the disease progression. About 1/3 of the patients scheduled for total joint replacement of the knee are potential candidates for an osteotomy. Surgical principles. The principle of treating medial unicompartmental osteoarthritis with varus deformity by shifting the mechanical weight-bearing axis laterally to relieve the medial compartment. High tibial osteotomy may delay the need for arthroplasty in young and physically active patients. It is regarded as an established procedure for medial osteoarthritis, showing good results. Aims and objectives. To evaluate the results of medial opening wedge high tibial osteotomy with Tomofix for unicompartmental osteoarthritis with reference to operative, radiological, and final functional outcome. The study design is descriptive and prospective, and the method of collection of data includes adult patients with unicompartmental osteoarthritis knee operated at SMIH hospital, and necessary radiological investigations and hematology were done on admission. Type of surgery and details were noted. The immediate post-operative X-rays were evaluated, and all the cases were evaluated again clinically, radiologically at 6 weeks, 12 weeks, and 6 months. The inclusion criteria includes all patients between 18 to 60 years of age with unicompartmental osteoarthritis, radiographic evidence of unicompartmental osteoarthritis, varus alignment up to 1 to 20 degree. The exclusion criteria includes the patients with bicompartmental and tricompartmental osteoarthritis, restricted range of motion at the knee, that is knee flexion of less than 90 degrees of flexion contracture of more than 20 degrees, patient aged above 60 years, and varus deformity of more than 20 degrees. This is the pre-op clinical image of the patient. This is the pre-op X-ray in which the angle of correction came out to be 18 degrees. This is the positioning of the patient and the limb marking. A 6 centimeter vertical incision is made over the center between the medial aspect of the tibial tuberosity and the posterior medial aspect of the tibia below the joint line, the medial joint line, and passed obliquely 1 centimeter below the lateral articular margin of the tibia towards the tip of the fibular head. These are the intra-op Siam images. Measuring tape is used for measurement, and oscillating saw is used in horizontal and vertical aspect to perform the osteotomy. If the opening of the osteotomy seems insufficient, 2 to 3 stacked osteotomes are used to reduce the risk of intra-articular fractures. Calibrated wedge is inserted and angle of correction is set until the osteotomy is opened to the desired extent. Ensuring under fluoroscopy with a long alignment rod centered of tibial plateau, which is known as the Fujisawa point. Osteotomy site is Osteotomy site is maintained with the help of minor spreader, and the internal fixation is finally done with the help of tomofix plate. This is the immediate intra-op C-arm image, and this is the suture line. This is the immediate post-op X-ray. Post-op scanogram after 6 weeks represents the line of the mechanical axis has now been shifted laterally, and it is going via Fujisawa point. In 6 weeks post-operatively, the pain and stiffness were absent, condition of the surrounding skin was normal, and range of movements was 0 to 100 degrees. This is the 12-week post-op X-ray, which is showing the consolidation at the osteotomy site. After 12 weeks, the range of motion of the patient is shown in this slide. In midterm analysis, it was analyzed on the basis of Knee Society score and Japanese Orthopaedic Association score. The osteotomy filling index was evaluated by dividing the total osteotomy length by 20% into 5 zones. As in this table, we can see on the basis of the Knee Society score and Japanese Orthopaedic Association score, the results were found satisfactory. The mean Knee Society score on 12-week follow-up is 180, as we can show in this, as we can see in this uprising graph. The mean Japanese Orthopaedic Association score on 12-week follow-up was 93.3. Discussion. After completion of this study, the result of the study corresponds to the studies done by Shakil Sarwar et al. In the year of 2019, Lespecio et al. In the year of 2017, and Piozzi et al. In the year of 2016. And all these studies suggest in patients with unicompartmental osteoarthritis, medial open wedge high tibial osteotomy with tomofix is an option to relieve the pain, and it also slows down the disease progression. Therefore, it can be considered a good option. Conclusion. 10 patients of medial unicompartmental osteoarthritis were admitted, operated, and followed, who were managed by mentioned technique in the previous slides, and based on our observation according to the Knee Society score and Japanese Orthopaedic Association score, the results were found satisfactory. We recommend in patients with unicompartmental osteoarthritis, medial opening wedge osteotomy with tomofix is a good option to relieve pain, and it also slows down the disease progression. Thank you.
Thank you, Ronak. To commence, you should be mentioning how much patients enrolled in your study, not in conclusion, but in the results section.
Okay.
Okay. As well as you should also be showing 1 or 2 slides of Japanese Orthopaedics Association scoring and Knee Society scoring as what was your tool. So questions from chair.
Dr. Ronak, it is a standard procedure, and the results have been highlighted by so many people. What was interesting, you have said your inclusion criteria is 1 degree to 20 degree of varus. So 1 degree varus also you will operate?
No, sir, it will be up to the 20 degree of varus deformity.
Huh?
Yes, sir, yes, sir. It will be up to the 20 degree of varus deformity.
And what's the lower limit? Up to 20, you said beyond 20 you will not operate. But 1 degree varus, is it worthwhile to operate for 1 degree varus? That was my question.
Sir, if the varus deformity, if the patient presented with clinical symptoms, and if we measure the varus deformity, and if it will be less than 20 degree, we will operate it by tomofix, medial open wedge high tibial osteotomy.
It's basically based on clinical problems, and then you measure it. Basically, your clinical problems tell it.
Yes, yes.
Dr. Ronak, you had this topic has been studied upon since a number of years. I remember during my time, we had a certain very close friend, Dr. Vinod Saxena, who was also working on high tibial osteotomy. Is there any difference down the years line, 32 years, 33 years down the line? Is there any difference between your study and a study done 33 years back and down the line? Very short, within half a minute.
So now we are getting a better implant option for this surgery, and there are further options like high fibular osteotomy and the osteotomy using the orthofix implant. Also for the younger patients who are suffering from unicompartmental osteoarthritis. So that's why this tomofix is a good option for treating the patient with unicompartmental osteoarthritis.
Question from Dr. Rastogi.
I think we'll have the last one. Dr. Rastogi, just round up yourself, please. Instead of the question, you give your comments.
To ask one question. What was your average varus in all your 10 patients, pre-op, post-op, and at the end of your follow-up?
Sir, the pre-op, the average varus was found to be 17 degrees.
Okay.
Yes, sir. And post-operatively, after we have corrected the angle, we have only taken the functional outcome as the main results for the patient. We have not taken the varus, average varus at the final presentation.
But then your study would not be very rigorous if you could not quantify your pre-op, post-op, and also loss of angle in the post-op period. So I think that is one aspect you should improve in your.
Yes, yes, sir. I will include that. Okay. Yes, sir.
Dr. Ipanshu can load his presentation. And Dr. Ronak, final question is, what are the contraindication for high tibial osteoarthritis?
Sir, contraindications include the tri-compartmental or bicompartmental osteoarthritis. We have to go for total knee replacement in this, as the main indication for this is unicompartmental osteoarthritis.
Any other contraindication?
Sir,
Dr. Ronak, do you see any instability before do assess the instability of the knee?
Yes, sir.
Before doing osteotomy, do you assess the instability of the knee?
Say the instability of the knee was also taken pre-operatively in view, and we have checked the patient's instability.
Dr. Ipanshu?
Yeah, we'll move on, I think.
Yes, sir.
Load your presentation, please. Start sharing your screen. So he'll be talking on Dr. Ipanshu from Pandit B.D. Sharma College. He'll be talking on treatment of recurrent giant cell tumors of the bone in the extremities.
Good evening, everyone. Myself Ipanshu Malik from PGIMS Rohtak. My topic for presentation today is treatment of recurrent giant cell tumors of the bone in the extremities under guidance of Dr. Zile Singh Kundu. The giant cell tumors are treated with extended curettage or resection with varying range of recurrences. This is our standard protocol for every GCT we treat, whether it is of distal radius, proximal tibia, or distal femur, which are the most common presentations. And depending upon the treatment and the local presentation, the recurrence rates have been ranging from 0 to 65 degrees. And after extended curettage, the recurrence rate was 10 to 20 degrees, and it is less than 10 degrees after intralesional resection. Our aim was to study how the recurrence should be treated and what was the outcome after further surgeries. We had a total of 24 patients, out of which 14 were females and 10 were male patients. The age ranging from 18 to 44 years with mean age of 29 years. And out of these 24, the 16 recurrences had occurred after curettage and 8 after resection. And out of these 24, the 18 were contained either within the bone or with extent into soft tissue, and 6 isolated recurrences in soft tissues. Now their X-rays were evaluated as per Campanaki radiological grading, and out of these 4 were Campanaki grade 2 and 14 were Campanaki grade 3 with soft tissue extension. The distal radius, the recurrence site, it is the commonest recurrence site for the GCTs, and followed by the proximal tibia. It is not true as of the primary GCTs. And the mean follow-up period in my study was 45 months, ranging from 24 to 120. And the important point was, out of these patients, the 18 were treated by general orthopedics surgeons in periphery, who were not trained specifically in orthopedic oncology. It is an X-ray. It is an X-ray showing GCT in distal radius. Previously, it was treated with curettage and bone grafting, and the patient had recurrence, which was treated with again the extended curettage and cementing. Now this is a patient clinical photo showing a distal radius GCT. It is our incision. It is an AP and lateral views, which was treated previously with curettage and bone grafting. We did intralesional resection, And we did arthrodesis of the wrist with the centralization of ulna. What were our results? There occurred 2 re-recurrences in distal femur. And out of these 2, one was treated with resection megaprosthesis and other with the amputation. The patients with joint preservations treated with further curettage and those where resection of soft tissue recurrences was done with salvage of bone and the one with prosthetic replacement had better functional outcome with mean MSTS score of 26.77 ranging from 22 to 30. And with arthrodesis, the average score was 24.58 ranging from 22 to 26. And the overall average MSTS score was 24. What we concluded was the local recurrences in grade 1 and grade 2 after curettage in long bones can be treated with further curettage and cementation or any other filler with minimal further comorbidity. And the soft tissue recurrences, they are easily re-excised. The grade 3 lesions with extensive soft tissue involvement were treated with resection reconstruction in similar fashion. The primary lesions in the same grade and extent. The re-recurrences rate after proper treatment does not increase much. The recurrent lesions are usually not histopathologically different from the primary lesions and need not to be taken as the malignant transformation. However, their resection becomes difficult due to fibrosis and loss of tissue planes. And these should only be treated by an orthopedic oncologist who is trained in these and not by a primary orthopedic surgeon. Thank you.
Thank you, Ronak. Thank you, Panshu. A lucid presentation. Only thing you were a little nervous when you were talking about percentages, you were mentioning the degrees in them. Second, slides are a little more crowded. You could have extended your slides. Now, questions from chair.
Yes, I think what Shivam said is right. You have got only 8 slides. You could have tell the same thing in 16 slides. It would have been much better. When you have these cases where you did curettage bone grafting again,
yes, sir.
The recurrence was totally intralesional, or it has come out in soft tissues?
Sir, there was out of these 4 had recurrence also in the soft tissues, which was for which excision was done.
Because usually what happens if the recurrence occurs,
yes, sir.
It is these tumors are embedded into the scar and other areas through which the original surgeon has gone in.
Yes, sir.
So one has to take care of removing everything there.
Yes, sir. We took in this case around soft tissue was all involved soft tissue was excised along with the neighboring normal tissue to be a safe landmark, and the scar mark was also excised, which was sent for biopsy.
Okay.
Do you compare both the biopsies? The biopsy which was done for primary and the biopsy which was done in recurrence?
Yes, sir. We compared both the biopsies.
With what? Simple biopsy, or did some immunohistochemistry as well?
Sir, simple biopsy. No immunohistochemistry was done.
You should be more elaborative in your results. So this is a very good study. But at the end of your presentation, we are a little confused that what was the site of recurrence? You told that it is distal radius, but how much was the other sites? And what was done separately for it? A master chart or something like that would have made it more informative. Very good study.
Thank you, sir, for feedback.
Can we have Dr. Sachin uploading his slides? I think we are running on time, before running late. Dr. Sachin? Is Dr. Sachin here? In the meanwhile, can we take another question? If Dr. Sachin is not listening, can we have Dr. Saurabh Singh?
Yes, sir.
Who's that? Yes. Do we have Dr. Sachin Sachdeva or Dr. Saurabh Singh? Anybody? Or are they absent?
Dr. Saurabh is online. I think if he is ready with his presentation, he can go ahead.
I think you can proceed. Okay.
Good evening, sir.
नंबर को कॉल किया है वो फिलहाल स्विच्ड ऑफ
Dr. Saurabh or Dr. Sachin? Who is responding?
Good evening, sir.
This is from Dr. Ipanshu.
Dr. Sachin.
Dr. Sachin. So we were asking you, you were not responding. So can you
Sir,
load your
actually,
presentation?
I'm not able to share my screen. There's some kind
Not
of...
able to. Okay, the other person, next person.
Dr. Saurabh.
Dr. Saurabh Singh is on seen there.
Both are there, but probably they are not able to load it.
Yeah.
Dr. Saurabh is sharing the screen.
Okay.
And he'll be talking
whoever wins first, right?
Role of platelet-rich plasma in treatment of chronic Acl tendinopathy. Dr. Saurabh, are you able to listen us?
I don't think he's audible.
His slides are visible.
I think he would be having an issue putting on his audio or is getting off the mute or sharing his screen.
Yeah,
I think they're not used to that. I think all presenters in the future will do well to be getting tuned with the presentation and the sharing of the screen on these platforms.
Good evening, everyone. Hello.
Yes.
Hello. Good evening, everyone.
Yes.
Hello. Hello. Am I audible, sir?
Yes, Sachin, you are audible. Go ahead. We'll appreciate if you can cut short about a minute of your.
You are streaming the live stream. You are yes. Okay.
Good evening, respected all the faculty members. Myself, Dr. Saurabh Singh. My topic is on role of platelet-rich plasma in treatment of chronic Achilles tendinopathy under the guidance of Dr. Professor Rohit Nath sir. Hello.
Yes.
Yes, you are
Continue.
audible and visible as well. Continue.
Okay. Achilles tendinopathy is a chronic activity limiting syndrome that is generally defined by presence of pain and thickening in Achilles tendon. The lifetime prevalence of tendinopathy is about 52% in runners, informal runners, and whereas the annual incidence is about 7 to 9%. Now, generally tendinopathy occurs as a result of overuse injury caused by repetitive energy storage and releases with excessive compression. This may lead to, in worst case scenario, it may lead to rupture of Achilles tendon. Now, we can, as you can see on the screen, the model that has been proposed by Cook and Purdom regarding the staging of tendinopathy. It's a cycle. Basically, there are 3 stages of transformation of normal tendon to the stage of tendinopathy. The first stage is reactive tendinopathy, followed by tendon disrepair, and finally the tendon Achilles tendon. Finally, the chronic tendinopathy. It has been suggested that tendon can move up and down this continuum, and this can be achieved by adding or removing the load from the tendon. The biggest cause is the excessive overburdening of the tendon. Now, tendinopathy is generally of 2 types: the insertional one and the non-insertional one. Insertional one is when it is up to the 2 centimeters from the insertion of the tendon, and the non-insertional one is from 2 to 6 centimeters from the insertion. When talking about the etiology of the disease, basically it is generally seen in patients who generally are active in their day-to-day life. Also, where there is overuse of Achilles tendon, people who are generally overweight, when the training and exercising is not proper, using inappropriate footwears. All these people are generally prone to develop Achilles tendinopathy. The most common, or perhaps the most important, is the malalignment of ankle caused by hyperpronation of the foot. Also, people who are taking ciprofloxacin or some group of fluoroquinolones, they are also prone to develop tendinopathy. Clinical presentation: morning pain is the hallmark symptom because the Achilles tendon must tolerate full range. Besides this, swelling and pain are less common. Although other than this, occasionally patients may have bone spurs, or sometimes they may present with a constant swelling that may get worse throughout the day without the activity. Okay, when looking at the features on the color Doppler, generally there is increase in intratendinous vascularity in Achilles tendon, along with the abundance of vessels, which is found on the ventral aspect. On USG, we generally tend to see the peritendinous adhesions. On MRI, which is the gold standard, it generally provides extensive information on the internal morphology of the tendon and the surrounding structures. Talking about the PRP types, generally there are 4 types: pure PRP, which is low WBC count and low density, whereas the PRP chronic Achilles tendinopathy. Aim and objectives. The aim of our study is to assess the role of leukocyte-rich PRP in the treatment of chronic Achilles tendinopathy, which has been evaluated in terms of self-reported tendon pain during activity, which has been assessed using visual analog scale, function and symptoms, which has been assessed using VISA-A score, and tendon thickness and vascularity, which has been assessed using USG and color Doppler, which was carried out within a duration of 2 years. All data was expressed as mean and standard deviation. An analysis was done using the available InStats software. Talking about the inclusion criteria, the patients who were having clinical and radiological symptoms, features of Achilles tendinopathy were included in the study, and patients in whom symptom duration was more than 6 weeks. Patients less than 18 years, in patients where there is clinical and USG indications of other musculocutaneous injuries, patients who have had previous steroid injections or any kind of blood products, patients who have been treated with fluoroquinolones in the last 6 months, and patients with systemic disease such as diabetes, generalized inflammatory arthritis, or radiculopathy, osteoarthritis, previous shock wave therapy were excluded from the study. This is a technique
Dr.
of
Saurabh, you're running a minute, just the last minute in your talk. Proceed.
Yes, sir. Yes,
just the last minute in your talk. You'll have to hurry up.
Please stick to time. Yes.
Hello.
You are not audible, Dr. Saurabh.
Sir, I'm not. Oh, okay, yes, sir. In our patients were meeting the inclusion and exclusion criteria were selected. Post injection patient weeks and then up to 18 weeks. The minimum. Hello.
Yes, you are audible now. Please.
Hello.
Yes, continue.
Hello.
Yes,
you are
continue.
audible now. Please continue.
Yes, doctor, you're audible. Please go ahead.
Okay. Out of 62 patients, 32 were males and 30 were females, where they with slightly high incidence in male population. The mean age of presentation is 39 years. Minimum age was 27 years. This is
What is happening?
He's
losing.
I think he seems to be having some
Wi-Fi is lost.
connectivity issues.
I think he has lost the link. Lost the internet linkage.
Yeah. His screen is coming, but his audio is not coming.
But his screen is staying there, sir, for a very long time.
Yeah.
He must have changed it, and it's still the old screen which is visible.
Dr. Saurabh, are you there? Dr. Saurabh?
He's
lost.
Short of his time by 2 minutes. I think we have to proceed. I think you will have to proceed. And can you take the questions, Dr. Saurabh? No, once he can't listen to us.
Dr. Arun, I don't think he can hear you.
Yeah. So let's proceed on to the next one. I think we'll have to stop over here. We have time restrictions.
Right.
I think we'll have to take a call on it. No questions would be asked.
Yeah, but we have
Do
one
we have
more.
Dr. Sachin here?
Yes, sir.
Dr. Sachin, can you share your slide?
Yes. Yes, sir.
But we will have to ask Dr. Saurabh to stop sharing the slide first.
Yes. So,
Good morning, everyone. Yes. Good evening, everyone. I'm going to present a study on prospective randomized study comparing bone transport versus muscular technique in infected gap non-union of tibia. Introduction. A non-union following fracture is a major orthopedic problem. The presence of infection and bone loss complicates the management of these fractures. There are various treatment modalities. Among them, bone transport is one of the most successful and worldwide accepted method of treatment for infected non-union of tibia. It usually involves adequate debridement of the necrotic and infected bone, followed by corticotomy for destruction osteogenesis. This principle, when used with circular or monolateral external fixator, allows regeneration of extensive defects of the bone and soft tissues. And the second is the muscular technique. That's a relatively new technique used in the management of large bone defects. It is based on two principles. The formation of induction membrane. After bone debridement, the defect is filled with antibiotic impregnated bone cement. The cement is kept for a period of 6 to 8 weeks. This allows the formation of induction membrane, followed by the cancellous bone grafting. After a period of 6 to 8 weeks, the bone cement is gently removed. The defect is filled with cancellous bone graft. Defect as large as 25 centimeter can be managed with muscular technique. Material and methods. Total of 25 patients were taken with infected non-union of tibia were included in the study. 13 were treated with bone transport technique and 12 patients were treated with muscular technique. Inclusion criteria: the patients with infected non-union of tibia, a gap of less than 6 centimeter at the fracture site were taken into the study. Exclusion criteria were all the non-pathological fractures with bone disorder or any systemic debilitating disease, hormonal disorder were excluded. Assami scoring was used for study in which the bone results and functional results were taken. Bone results include union, infection, deformity, and limb length discrepancy, which are graded as excellent, good, fair, and poor. And the functional results include the daily activity, pain, limb stiffness, and graded as excellent, good, fair, poor, and failure. In the bone results, it is seen that the bone transport groups have shown the better results than the muscular technique group. And in the functional results also, the bone transport group has shown better results than the muscular technique group. These are the photos. In the bone transport group, on the left side, we can see a pre-operative radiograph of the right leg with external fixator in situ. And on the right side, we see a post-operative radiograph at 3 months follow-up, showing distraction at corticotomy site. On the left side, radiograph at 6 months follow-up, showing malalignment at the docking site. And on the right side, radiograph at 9 months follow-up after fixator adjustment. On the left side, radiograph at final follow-up. And on the right side, clinical photograph showing no limb length discrepancy above and below the good range of motion. Second case of bone transport group. On the left side, we see a pre-operative radiograph of the right leg and the immediate post-operative radiograph of the right leg. On the left side, this is a radiograph at 6 months follow-up and at the 15 months follow-up on the right side. Radiograph at the final follow-up and clinical photograph also showing stiffness at the knee joint. Muscular technique group. This is a pre-operative radiograph and clinical photograph of the patient with infected non-union of tibia following a roadside accident 4 months back. Intra-operative photograph after freshening of the sclerotic bone margins. And on the right side, we see an immediate post-operative clinical photograph following first stage of the muscular technique. On the left side, immediate that post-operative radiograph following first stage of the muscular technique, and immediate post-operative radiograph after second stage of the muscular technique showing bone grafting. Clinical photograph and radiograph showing consolidation of the bone graft at 6 months follow-up. On the left side, radiograph showing further consolidation of bone graft at 12 months follow-up. And on the right side, radiograph after railroad fixator removal showing consolidation of the bone graft and bridging of the bone gap at 16 months follow-up. Clinical photographs at the final follow-up showing good ankle and knee range of motion. Muscular technique case 2, pre-operative radiograph showing non-union of tibia following roadside accident 4 months back. On the right side, post-operative radiograph showing bone cement after first stage of muscular technique. Post-operative radiograph showing bone graft following the second stage of the muscular technique. And on the right side, radiograph showing consolidation of the bone graft at 6 months follow-up. On the left, we can see final radiograph showing union at consolidation of bone graft at 16 months follow-up, and clinical photograph showing good full knee range of motion. Clinical photograph showing the full ankle motion. Conclusion: distraction osteogenesis method of Elizarov has the potential to correct infection, deformity, bone and soft tissue loss, and limb length discrepancy simultaneously. The functional and the radiological results were comparable in both bone transport and muscular technique group. Overall, bone transport has better bone and functional results compared to the muscular technique group in patients with infected non-union tibia with bone loss up to 6 centimeter. Duration of fixator period and non-union in the muscular technique was more despite of less bone gap. A larger prospective study is recommended to further differentiate and give clear-cut guidelines in such challenging group of patients. These are my references. Thank you.
Very nice and lucid presentation. Few comments at you illustrated your cases well. Do you have any hypothesis? What was the reason that the results were good in the external fixator group or Elizarov group?
Sir, actually, in muscular technique group, what we faced the main problem was the infection. After the first stage, also in the second stage, the main problem was the infection. So we achieved union only in 50% of cases in the muscular technique group. And 2 of the cases we have to shift them to the bone transport group even for union.
Dr. Sachin, some of your cases showed very bad equinus. What was done to correct that equinus? How did you correct the equinus? One of the earlier case, external fixation had equinus, and then another point which I saw in external fixator group was that there is alignment was disturbed. So if alignment is not there, one could correct it at that time. Then you carry on that for 3 months or 6 months, and then bone unites in the Z-shaped manner. That is not good. It should have been corrected at this same go.
Sir, actually, it was corrected at the time when the bone reaches that stage, like at the time of union only, how much alignment is required at the final stage.
Actually, the fixator lost its hold. There was infection at the pin sides, and the fixator became loose. So it was a problem.
Yeah, that is true, I think. And that is one reason. Also, the fixator was applied too close to the fracture site. Should have spanned the entire bone.
Okay.
So that is one thing. The other thing.
Sir, you are muted.
Divided and
centimeter gaps.
Sorry, sir.
Internal fixature for so long, I think that is not very practical.
Sorry, sir. The voice is not clear.
Can you hear me?
Comments from Rastogi sir and KD Tripathi sir were not audible. Sir, Rastogi sir, can you just repeat it?
So his inclusion, one of his exclusion criteria were defects less than 6 centimeters.
Yes,
Why
sir. Sir, actually, we studied it for less than 6 centimeter, and in the literature, it has been seen that for large bone gaps, muscular technique was a better option. Like for a small bone gap, we
Muscular technique is better option for large bone gaps.
Yes, sir, for large bone gaps.
Can you quote a reference to it?
If
You
you
mentioned in one of the slides that you can take over the bone gap of more than 25 centimeters as well.
Sir, up to 25 centimeters. Up to 25.
If you look at the literature closely, in the lower and the middle tibia, if you have got more than a 7 centimeter gap, then usually the muscular technique fails. In the femur, it is good because you've got a lot of soft tissue, and but in the tibia it fails actually. So you did right by not taking gaps more than 6 centimeters for muscular.
Oh, thanks.
But I think your fixator positioning and this thing was not correct, and that is why you had poorer results in your muscular group as compared to bone drum.
Thank you, sir, for your feedback.
I think we are at past 7. Can we hand over the mic to the next session?
Okay, thank you.
Thank you.
Thank you very much. Thank you all the chairpersons and especially moderator Dr. Anoop sir. Thank you very much. Thank you Amit sir, Shivam and Kaushal Agarwal sir. Thank you very much.
Thank you. Thank you, boss.
Thank you.
Thank you. Goel sir, thank you sir. Thank you.
Thanks.
So with this, we come to the last and
thank you, Amit sir. Good evening. Amit sir, good evening.
So now we would like to invite the moderators of the session 3, Dr. Ajay Verma, Dr. Ankit Vashne, and Dr. Rajat Kapoor. I hand over the mic to Dr. Ajay Verma, Dr. Ankit Vashne, and Dr. Rajat.
पीछे हो गया
Hello everybody. Hello Ankit.
I can see Dr. Ankit is there. Hello. And
Hello Ankit. How are you?
454.
Am I audible? Am I audible?
Yes, sir, you are audible, sir. No, sir.
Okay. Our chairperson is Dr. Amir, Dr. Latif, Dr. Piyush Mishra, sir.
Yeah, good evening, Dr. Paul. I'm here.
Good evening.
Yes, sir.
Recording in progress.
Okay. I hand over mic to Ankit and Dr. Rajat. They will moderate the session. Please.
Good evening, all. Now I request our first speaker to present his talk, Dr. Ujjwal Singhal. Dr. Ujjwal, are you online? I want to invite our respected chairpersons, Dr. Amir bin Sabit, Dr. Latif Jilani sir, Dr. Piyush Mishra sir,
I'll just hi, I'm from Auto TV. I'll just clarify one thing. This is Hall A, and
yes, sir.
yes, and I just hope that everyone is supposed to know that they are in Hall A, and there is also a Hall B meeting going on.
Yes, sir.
Yes. Okay. Please go ahead.
Yeah. Session 3. I want to like to invite chairpersons, Dr. Amir bin Sabir, sir, Dr. Latif Jilani, sir, Dr. Piyush Mishra, sir. Good evening, Ankit, sir.
Hi, good evening, Rajat.
So I think we should start our session.
Please go ahead, Dr. Ankit.
Our first speaker, Dr. Ujjwal Singhal. Are you online?
Sir, I think he's not online.
Okay, Dr. Arshad.
I cannot see him in the participant list. So we can move ahead with the next speaker, sir.
Dr. Arshad.
Good evening. Yes, I'm Dr. Arshad.
Yeah. Please
can I
your
start?
slide. Yeah.
Okay. Yes, I'll share my screen.
Yeah, Dr. Arshad, start with your presentation.
You are not audible.
You are not audible, sir.
Sir, please
minimize your Zoom plan.
Share your screen.
Dr. Arshad, please share your screen.
Hello.
Yeah, Arshad, start
Am
with
I
your
audible?
presentation. Yeah, you are audible.
Am I audible? Yes.
Yes.
Can you see my screen?
Yeah. Start with your presentation.
Make it in the presentation mode.
Yes. Now it's in the slide mode. Is it in the presentation mode now?
No.
Can you see? No, not yet.
No.
Make it full screen, Arshad.
1 minute. 1 minute.
Okay.
Yes.
Yeah.
Yes. You are not audible, Doctor.
So when you share
your screen, you have to take the share with sound option.
So just
So just unshare your screen
and then
take the share with sound.
So Dr. Ujjwal has just joined.
So, sir, he will present after Arshad.
Okay.
Yes.
Hello, am I audible?
Yes, you are audible, Arshad.
Can you see the screen in full screen?
Yeah.
Yes. Coming to the topic of my study is short-term outcome of converting failed proximal femoral osteosynthesis to a total hip arthroplasty. Osteosynthesis can be successfully achieved in most proximal femoral fractures. After 12% of intertrochanteric fractures and 36% of femoral neck fractures may have fixation failure. A failed fixation surgery can be very distressing for the patient due to pain and disability. It is challenging to perform salvage operations in such cases. Failed internal fixation of proximal femoral fractures may be treated by revision osteosynthesis or converting into total hip arthroplasty. The indications to perform total hip arthroplasty in failed osteosynthesis of femoral fractures are poor bone quality, damage to femoral head due to previous internal fixation, avascular necrosis, poor bone stock, and limb shortening. In contrast to the revision osteosynthesis, THA will help in immediate immobilization, pain relief, and good rehabilitation. THA is generally accepted as the most successful treatment for failed proximal femoral osteosynthesis. The challenges of performing THA in these patients include difficulty in removing previous implant, poor bone stock, scarred tissues, increased risk of infection, difficulty in identifying bony landmarks, prevention of extrusion of bone cement. The aims and objectives of the study are: the purpose of the study was to describe the intraoperative difficulties in converting a failed internal fixation of hip into a total hip arthroplasty. The methods used to counter these difficulties, evaluate the functional outcome and complications of total hip arthroplasty in these cases. The Mittal method set was a prospective study done after approval from the Institutional Ethical Committee. The duration of the study was from December 2019 to December 2021. Inclusion criteria: patients with traumatic proximal femoral fractures having failed osteosynthesis as established by non-union, implant failure, or osteonecrosis of the femoral head were included. Absence of infection as ruled out by preoperative TLC, DLC, ESR, and CRP. The exclusion criteria: the presence of occult or active infection in patients with traumatic proximal femoral fractures with failed osteosynthesis or pathological proximal femoral fractures. Number of patients included were 24 hips in 24 patients. The male is to female ratio was 18 is to 6, and mean age of these patients was 62 years, a range of 40 to 79 years. 18 patients had a femoral neck fracture, and 6 had intertrochanteric fracture fixation failure. Surgical procedure total hip arthroplasty was performed by an orthopedic team headed by the same surgeon under the regional or general anesthesia with prophylactic antibiotic cover. All surgeries were done in a single stage. Cemented or uncemented THA was performed depending on the age, bone quality, bone defects, and affordability. We preferred uncemented THA in young and active, and cemented THA in older patients. However, bone quality and affordability were major determinants for making a choice between the two in our case series. None of the patients had a defect in acetabulum, so grafting was not done. Surgical approach used was posterior in 3 cases with a failed CCS fixation and anterolateral in rest 21 cases. Difficulties encountered in converting a failed intertrochanteric fracture osteosynthesis into THA were abnormal position of the trochanter mass because of rotation defect, and difficulty in intraoperative identification of limb length due to loss of usual landmarks such as a rest trochanter. While implanting cement stems, cortical lag screw holes were closed with either bone grafts or by assistant surgeon's thumb finger. Some cement extrusion was still seen medially. Attention was paid to preserve or maintain the integrity of abductor mechanism. Difficulties encountered in converting failed femoral neck fracture osteosynthesis to THA were less compared to intertrochanteric fractures. There was less incidence of cement extrusion, and identification of bony landmarks for intraoperative referencing was also comparatively easy. Hip stability was checked before the closure of the wound. Uncemented THA was done in 7 cases, and cemented THA in 14 hips, and hybrid in 3. The results were the average follow-up was 18 months in our study. The mean duration of the study was surgery was 110 minutes. The mean blood loss was 500 ml. There was one dislocation postoperatively in a patient with a failed intertrochanteric fracture. This post-op dislocation was reduced by a closed method. There were 2 superficial infections that responded to conservative treatment. There was no aseptic loosening of THA components. The mean Harris hip score increased from 34 preoperatively to 76 postoperatively at the final follow-up. Discussion: the reported failure rate with internal fixation for intertrochanteric fracture is in the range of 3 to 12%, with device penetration 2 to 12%, non-union 2 to 5%, malunion 5 to 11, causing various deformity. Similarly, in displaced fracture neck of femur, 20 to 36% of the patients initially treated with internal fixation required revision within 2 years because of non-union or avian of the femoral head. Parker et al. Also showed a reoperation rate of 40% for displaced femoral neck fractures treated with internal fixation. THA in failed internal fixation devices frequently takes a longer time with increased blood loss. Risk of mechanical complications like cortical fractures is also high due to poor bone stock, holes after removal of hardware combined with distorted bony landmark. No such complication was seen in our study. Literature shows complications like infection, dislocation, fracture, and implant failure in these cases. In present series also, there was a 4.2% one post-op dislocation, which was operated by posterior approach. 2 patients in present study also developed infection. In our study, 21 out of 24 THAs were performed through a anterolateral approach and only 3 by posterior approach, which may have contributed to a low dislocation in our series. Other cause of low dislocation in our series may be due to large number of failed fracture neck of femur rather than intertrochanteric fractures. Several authors have found salvage THR for failed intertrochanteric fractures to be more difficult with a higher potential for complications than salvage THA for failed femoral neck fracture. An overall low complication rate in our study could be due to low number of failed intertrochanteric cases in our study. Also supports their observations. Despite this finding, Hadjukevich et al. Reported relatively few complications and good pain relief and function in their large series of salvage THA and failed IT fracture. By contrast, McKinley and Robinson reported poor outcomes in their series of salvage THA for failed subcapital fractures. The clinical case exhibits is a 40-year-old male sustained injury to his right hip and had a fractured neck of right femur for which cannulated CCS were done. 1 year later on, the patient developed AVN for which cemented THR was done 2 years later. Another one is a 79-year-old male operated for femoral fracture neck of right femur. CCS was done. Later on leads to AVN for which hybrid THR was done 25 months later to the primary surgery. A 66-year-old female where THA was done with failed DHS converted to a THA. 63-year-old male operated with CCS for fractured neck of femur. Later on developed implant failure for which cemented THR was done 6 months later. A 65-year-old male had intertrochanteric fracture. He was operated. DCS was done, which went into non-union. Later THR was done, which dislocated postoperatively, and closed reduction was done. Conclusion: hip arthroplasty performed after failed internal fixation of the proximal hip fractures is typically more difficult than routine primary THA. Despite challenges, THA is good salvage surgery after failed osteosynthesis of hip fractures. Most patients have good pain relief and functional improvements in spite of technical difficulties during procedure, and higher complication rates than primary arthroplasty. These are my references.
Thank you, Dr. Arshad. Any questions?
Dr. Arshad? Dr. Arshad?
Yes.
Yeah, a nice presentation. Could you tell me, you said that we have used anterolateral approach, that is the chance that we have lesser dislocation rate. Does anterolateral approach always say that there's lesser dislocation rate? There can be even dislocation rates in anterolateral approach also.
Yes, sir. There is a possible dislocation, but the
approach and you do a proper posterior repair, you may not have any dislocation rate.
But still, when the patient attempts to squat or sit cross-legged, sir, the hip can it can dislocate when the capsule is weak after you repair it.
Okay, so most of the you didn't thought of putting some long stems or the dual mobility cups for intertrochanteric fractures, and why was the option of the total hip taken into account when bipolar at the age of 79 can be thought of? 79. I'm specifically asking for the 79-year-old age group patient.
Yes, sir. 79-year-old age group patient. Here, hybrid THR was done 25 months later to the primary surgery, sir.
Yeah, that is fine, but we could have easily opted for the bipolar. We could have prevented a dislocation. The chances of dislocation with a THR is more as compared to a bipolar.
Compared to that of
case.
This osteoarthritis
One
of
more
the
question.
hip.
Dr. Arshad?
Yes, sir.
One question. There have been many previous studies for this intertrochanteric fracture. So, what new are you adding to the literature? I mean, the USP of your study.
Pardon me?
I mean, they have reported many previous studies on this subject. So, what is the, I mean, the new or USP of your study? What is the new thing you are doing? Like normally when we are doing any research, we have an objective that what new we can get out of our study.
Yes, sir.
I mean, you can start and try to find something new which you can add to the literature. You have already a very good case series.
Yes, sir.
So try to focus on something which you have already not been discussed earlier. Please review again and I present something which is you can give it as a remarkable. Thank you.
Yes, sir. Thank you, sir.
Any more questions? I would request our next participant to please start this slide. And while we are having a question answer session, please the next participant to kindly keep his presentation ready.
Dr. Ujjwal, he's joined, I think.
Yes, sir. Dr. Ujjwal here, sir. Am I audible, sir?
Yeah, share your slide, Ujjwal.
Yes, sir. Is my slide visible, sir?
No.
I'm trying, sir.
Share screen option is there.
Yeah, share screen option is there, sir. And when I open it, there are multiple options shown to me. Wait, sir. I'm trying, sir.
Next candidate, Dr. Noor Alam. Is he there? Dr. Noor Alam, are you there?
Sir, I am there, sir. I am trying to share my presentation, sir.
Okay.
Actually, sir, I am using MacBook and
Already ready with this presentation.
Anybody ready with this presentation in this session?
Yes, sir. Dr. Deepak here. I'm ready with my presentation. Can I share my slide?
Yeah, share your screen.
Just a second, sir. Give me a second.
The left out presentation will be taken after Dr. Deepak.
Yes, sir. Is it? Can you see the slides?
No, not visible.
Okay.
I think if multiple people are trying to share the screen.
Dr. Aris or Dr. Deepak Batija.
Yes, sir. I'm trying to share, but there is some issue. Just give me a second.
Only one speaker share your screen, not all.
sir, I am trying here. Actually, the system is granting access from security and privacy, but when I am opening it, nothing is there, sir. I do not see the option where the screen will be shared, from where the screen will be shared. I'm trying, sir.
Is Dr. Arshad with you?
No, sir. Dr. Arshad is not with me currently.
Okay.
I am trying. I shall try it in my mobile then, sir.
Okay, try it with mobile if possible.
Okay.
Then share your screen.
Yes, sir. I'm doing.
Dr. Fazal, are you there?
Somebody has shared.
Yeah.
It is Deepak Bhatteja.
Hello, good evening, sir. I am here, Dr. Fazal.
If any
Yes,
of the speaker able to share his screen.
Yes, sir. Dr. Deepak, this side. Can you see my
Yeah,
slides?
start with your presentation, Dr. Deepak. And
Okay, so
rest left out will be present to be present after him.
hello everyone, myself Dr. Deepak. I am presenting my work on total hip replacement in tuberculosis of hip, and my guide is Professor Amir bin Sabir sir. Tuberculosis is endemic in Indian subcontinent, with osteoarticular tuberculosis accounting for 1 to 3% of all the cases. TB of the hip joint constitutes approximately 15 to 20% of all osteoarticular cases, and TB of the hip is the second most common site of bone involvement after the spine. The common age of presentation is in the second and the third decades. The aims and objective of my study were to evaluate the clinical results of total hip replacement in tubercular arthritis, to assess the post-operative hip function using Harris hip score, to evaluate the complication of total hip replacement in tuberculosis hip. My study design was a prospective study and was done in Department of Department of Orthopaedic Surgery, Jawaharlal Nehru Medical College, Aligarh, from December 2019 to November 2021. Inclusion criteria was patient with stage 2 and onward tubercular arthritis, patient without sinus tract into the pelvis or thigh, patient who were motivated for the surgery and willing to take anti-tubercular chemotherapy post-operatively. Exclusion criteria was skeletally immature patients. Pre-operative, we did a pre-operative planning by clinico-radiological parameters. Clinical history was taken, detailed physical examination was done. Hemogram with ESR, CRP, acute phase reactants were sent. X-ray of the pelvis with bilateral hip and MRI of the affected joint was done. This is the pre-operative templating X-ray to determine acetabular offset, femoral offset, and shortening. The scoring system used in my study was Harris hip score, which has 4 domains: pain severity, function, absence of deformity, and range of motion. Score was excellent in the range of 90 to 100, good in the range of 80 to 89, fair in 70 to 79, and poor less than 70. All the patients, coming to surgical approach and technique, all the patients were placed in lateral decubitus position with trunk and pelvis well supported. Southern Moor approach was used in all the patients. After the exposure of the head, osteotomy of the head was done. The entire cacheating and infected material was taken out, and a thorough debridement of infected tissue was done. Acetabular cavity and femoral femur was prepared. We used cemented, uncemented, and hybrid implants in all the patients, and the infected material was sent for histopathological analysis. These are the histopathological slides showing the tubercular granuloma with central cacheating necrosis surrounded by Langen-Giant cells and the tubercular Langen-Giant cells. Observation and result: total hip arthroplasty was performed in 5 patients in the age group 27 to 76 years with the mean age of 48 years. There were 4 males and 1 female in my study. Right side was involved in 2 patients and left side in 3 patients. Coming to pre-operative Harris hip score, 1 patient has Harris hip score in the range of 0 to 9, 2 patients in between 20 to 29, and 2 patients between 50 to 59. The average mean of pre-operative Harris hip score was 32.08. Then we did sequential follow-up of the Harris hip score at 6 weeks, 12 weeks, 6 months, and final follow-up. The average pre-operative Harris hip score of 32.08 finally improved to 90.5. This is the graph showing the same. 2 patients had excellent result with the Harris hip score more than 90. 2 patients had good results and 1 patient had poor result. Anti-tubercular chemotherapy was started in all the patients right from the day of admission and continued till 18 months post and continued for a total duration of 18 months. We started with schedule 13 for the first 2 months and schedule 14 for the next 16 months. The average pre-operative Harris hip score of 39 improved to 9.75 at the final follow-up. Here is the graph showing the same. And the average CRP improved from 49.76 to 2.17 at the final follow-up. The pre-operative limb length shortening of 1.9 centimeter improved to 0.5 centimeter post-operatively. We used cemented implants in 3 patients, uncemented in 1 patient, and hybrid implant in 1 patient. Complication: 1 patient developed intraoperative breach of the cortex. She was managed conservatively. She was put on bed rest for 3 months, and partial weight bearing was allowed after 3 months. 1 patient developed dislocation and wound gaping on the day 25. The patient squatted against advice. The patient was taken to emergency OT where close reduction was done and secondary suturing was done. We have compared the results of our study with Yoon et al., Niage et al., Wang et al., Sidhu et al., Asturkman et al., Malhotra et al., Zeng et al. The mean number of patients in our study was 5 with the mean age 48. The mean preoperative Harris-Hip score was 32.08. ESR and CRP became normal at 3 months and 5 months respectively, which is comparable with the results of other studies. The preoperative ATT we started from the day of admission and continued till the day of surgery and then further up to 18 months. 3 cemented, 1 hybrid and 1 uncemented implant was done, and the final post-op Harris-Hip score was 90.5. Post-op ATT continued for 18 months and the follow-up was 16 months. No cases of reactivation were there in our study. In summary, a total of 5 patients were operated with the mean age 48. Anti-tubercular chemotherapy started from day of admission till 18 months. All patients were treated with primary total hip arthroplasty. Mean pre-op Harris-Hip score improved to 90.5 post-operatively. No, there was no sign of reactivation. 1 patient developed intraoperative breach of the cortex and she was managed conservatively. 1 patient developed posterior dislocation and wound gaping and was managed conservatively. Conclusion, our study concluded that total hip arthroplasty can be done in patients with active advanced tuberculosis of hip and secondary osteoarthritis in heel tuberculosis. There is no need to delay for a long latent period. Duration of ATT preoperatively doesn't affect the result of total hip arthroplasty, but duration of ATT is crucial for the success of THA. There is no difference in result of cemented or uncemented implant. Complete curettage of infected tissue intraoperatively and adequate post-operative chemotherapy are important to prevent any reactivation of infection. 1-stage total hip arthroplasty can be carried out in patients without sinus tract into the pelvis or thigh, as these patients are poor candidates due to incomplete curettage of infected tissue. Careful post-operative limb positioning and mobilization under supervision are important, especially in the early post-operative days. In nutshell, THA is safe in active advanced TB hip, providing stable function and painless joint. The limitation of our study, average follow-up of our study was 16 months, which may not be enough to determine the reactivation of infection. Sample size of our study was small due to COVID infection. Thank you. These are the case. These are the case exhibit. This is first case. He had TB of the left hip joint with associated port spine of L2, L3. The patient was on bed as his neurology was poor. Patient was started on ATT. And 3 weeks after starting of ATT, total hip replacement was done. And these are his pictures at the final follow-up. Patient was walking normally and he is able to do the single leg stance. In all the cases, we have sent histopathological samples and results and final diagnosis was made on histopathology only. Here is another case. This patient developed intraoperative breach of the cortex. These are our follow-up X-rays. Patient is walking with pain and the Harris-Hip score is poor. This is the case showing the poor outcome in our study. Thank you.
Dr. Deepak, you have compared your study with few other studies which are present in the literature. Most of the studies always take into consideration the time duration of the AKT started preoperatively. You have mentioned in your talk that it doesn't matter, but when we are comparing it, we have to have a data accordingly. You have told in one case that it was 3 weeks. What was the average time that you took into consideration?
Sir, in 4 patients, we started ATT right from the day of admission, and average it was around 1 week only. In 1 patient, we even started post-operatively. But 1 patient had completed 12 months of anti-tubercular therapy. So we did total hip replacement. He developed secondary osteoarthritis. So we did THA, and thereafter we gave him an ATT for 6 months.
Okay, so if the patient a known case of tubercular arthritis after 4-5 years he comes to us, would we be starting AKT or we can do directly a total hip replacement in it?
Sir, in these cases, literature has mentioned that there is one paper by Malhotra et al. 2015. He states that in such cases we should start ATT 2 weeks before surgery and should continue till 6 months after surgery. But in our case, as there was one case, he was already on ATT for the last 12 months. So, so there was no case as you have mentioned the scenario, sir. After 4-5 years, the patient is presenting to us. All the patients were
okay. And did you use any antibiotics in the cement?
No, sir. We have not used any antibiotic in the cement.
Okay. So this study needs to be taken into consideration for a longer time, and the sample size has to increase. You have already mentioned it, but just for discussion purpose, it has to have a bigger sample size as compared. But nowadays, we don't follow this protocol of keeping a long latent period. We can immediately go in for a total hip, even in an active case of tuberculosis. There's only one indication that we usually don't do total hip. If there's a
So that
draining,
is sinus tract into the pelvis or thigh.
yeah, that is fine. Apart from that, if it's a draining pus on opening the hip joint and you find there's a draining pus out of it, then it's better to avoid it, put a space and come back. Don't do to a THR. Some say that even in that phase you can do, but a little risky, I think, in my consideration. Dr. Amrit sir, what is your opinion about it? Or if Dr. Amir says there.
Can we switch over to next candidate? I think Amrit there. I think.
Okay, okay, sir.
Next candidate, please. Noor Alam.
Thank you, sir.
Okay, thank you. Enlarge your screen.
Am I audible, sir?
I think you are audible. Please.
Is my screen visible, sir?
Yeah.
Good evening, everyone. I am Dr. Ujwal. I am here to present my research title, Randomized Control Study Comparing Hamstring Graft and Peroneus Longus Tendon Graft in Arthroscopic ACL Reconstruction. My guide is Professor Nayyar Asif, sir. Coming to introduction, bone patellar tendon bone is considered the best graft choice for ACL reconstruction. Bone patellar tendon bone graft has bone-to-bone healing, which permits effective incorporation of graft into tunnel, leading to faster returns to sports activity. But however, it carries a risk of patella fracture and anterior knee pain, invasive approach, large incision, fixed length, and a graft which is weaker than native ACL. Thus, hamstring autograft is used, which is easy to harvest, which has minimal donor site morbidity, and it has strength, which is comparable to that of native ACL. Hamstring tendon graft, however, has problems like unpredictable graft size, and it leads to potential decrease in hamstring power and thigh wasting. Many case series reported using the peroneus longus in ACL reconstruction with good clinical outcome and minimal donor site morbidity, while other studies do not agree due to donor site morbidity. Thus, it is still unclear which graft is superior in ACL reconstruction, as there is need for a graft which has properties close to native ACL with minimal donor site morbidity. My aims and objectives are to compare the results of arthroscopically assisted ACL reconstruction using peroneus longus graft and hamstring tendon graft in terms of graft parameters like diameter, graft length, subjective knee function, graft site morbidity. My need for further study is that no data currently, especially in a country, currently exists regarding recent trends in graft choices. No consensus exists over which graft is most appropriate for the patient. Many studies have been done regarding hamstring tendon graft and peroneus graft individually, each citing their own advantages and disadvantages. But there is very little literature available directly comparing both the grafts in our country and worldwide. This study will help to find out which graft is superior in ACL reconstruction, as there is need for a standard graft, thereby providing better outcome in ACL deficient knee. My null hypothesis. We hypothesized that the new graft used for ACL reconstruction, that is the peroneus longus tendon graft, will not be worse when compared to the standard treatment, that is the hamstring tendon graft, in terms of clinical assessment and functional outcome post-operatively. My materials and methods are, this study was a randomized control study, and randomization was done using computer generated tables on Microsoft Excel. The study, we proposed to include a minimum of 50 number of patients in each group. An institutional ethical committee clearance was taken for this. My inclusion criteria: patients with ACL injury who need reconstruction with no previous significant ankle injury or instability, patients without any prior intra or extra-articular ligament reconstruction, and patients who are motivated for surgery and willing to undergo required rehabilitation post-operatively. My exclusion criteria is severe osteoarthritic changes in the knee joint, evidence of loose bodies, and pre-ankle existing ankle deformity, poliomyelitis, paralytic condition, or any ankle morbidity leading to ankle disability. The Microsoft Excel was used to collect the data. Data was analyzed using SPSS software 26. Mean was calculated using descriptive statistics. Chi-square test was used to compare qualitative data. And for quantitative data, independent sample t-test and Mann-Whitney U-test was used. My sample size, Su et al. Did a study where he calculated lysome score between the two graphs. And following this, my sample size, based on the above findings, my sample size was calculated, which came out to be 34 number of patients with 17 number of patients in each group. This was done using sealed envelope calculator for continuous outcome non-inferiority trial. My observation and results. Total number of 40 patients were there included in the study, of which 11 were excluded and 29 patients were there which were randomized. 14 patients were there in peroneus group and 15 patients were there in hamstring group. And final analysis was done on 26 number of patients. Age distribution, mean age in the patients in both the groups was 24 years of age. Distribution of meniscal injury in a patients was in peroneus, and 2 patients had lateral meniscus and 8 patients had medial meniscus injury. And in hamstring group, 4 patients had lateral meniscus and 5 patients had medial meniscus injury. The results were non-significant. Mean follow-up period in peroneus group was 16 months and in hamstring group was 18 months. Distribution of graft parameters. The femoral graft diameter in peroneus was 9.14 compared to hamstring graft, which was 8.27. Significant difference was found in the femoral graft diameter between the peroneus longus and hamstring group. The tibial graft diameter was also a significant difference was there in the tibial graft diameter between both between the peroneus and hamstring group with p-value less than 0.01. Mean length of the graft was the length of peroneus graft was 92.86 and in hamstring group it was 89. And the significant difference was found between the total length between the hamstring and peroneus longus tendon graft. In the subjective scores distribution, the pre-op in both the groups, that is the peroneus and hamstring group, pre-operative and post-operative, significant improvement was seen in both the groups individually in the subjective scores like IKTC and lysome score. Mean improvement in IKTC score. The mean improvement in IKTC score in peroneus group was 34.95 as compared to hamstring group, which was 27.66, and the p-value is significant for this. Similarly, mean improvement in lysome score in peroneus group is 29, and in hamstring group it is 23.66, and p-value is significant, which is less than 0.05. The ankle functional scores in the peroneus group were comparable in pre-operatively and post-operatively, as the p-value was not significant post-operatively, thus signifying no significant ankle morbidity. Thigh wasting post-operatively in peroneus group, thigh wasting was 1.78, which was compared to 2.03 centimeter post-operatively in hamstring group, and the p-value was less than 0.05. Thus, a significant decrease in thigh wasting was seen post-operatively in hamstring group as compared to peroneus longus tendon group. The main complication in peroneus group was tingling sensation and pain, whereas in the main complication in hamstring group was numbness. And in 2 patients, there was infection of the incision site was seen. Coming to discussion, this is my patient's demographics. Mean age was similar to in our study as compared to the other studies, except the study done by Shi et al. This is my knee functional scores as compared to other studies. All the studies demonstrated better knee functional scores in peroneus group, except the study done by Wright-Me et al. However, the p-value was was significant in most studies, both in IKTC score and lysome score. The graft parameters, most studies demonstrated better graft diameter in peroneus group as compared to hamstring group. In ankle functional scores, our AFRs and FETA scores were comparable in our study as compared to other studies, with slight decrease in AFR score was seen. In conclusion, peroneus longus autograft may be a good alternative for ACL reconstruction. which showed good knee function as documented by significant good IKTC and lysome scores. There was minimal graft site morbidity as demonstrated by insignificant change in EOFAS and FADI score. Significant decrease in post-operative thigh wasting was seen in hamstring tendon graft. Hamstring graft is also difficult to harvest, often fell short in diameter, thus may lead to less strengthened graft requiring future revision by increasing burden on reconstructed ACL. Thus, peroneus longus is superior in terms of ease of harvest, adequate size, cosmetic appealing, excellent post-operative scores. Thus, our null hypothesis that peroneus longus will not be worse as compared to hamstring tendon graft is accepted. The limitations of my study include the small sample size, scanty number of female population due to less reporting, and COVID-19 pandemic affecting the proper follow-up, which affected the rehabilitation of the patients. Thank you, sir.
Why was there thigh wasting more in peroneus group than hamstring group than in peroneus group?
Sir, because thigh wasting was more in hamstring group because we take the graft from the hamstring which is close to the knee joint. So it contributed more to wasting post-operatively.
Okay.
It is as it is close to the knee joint, whereas peroneus is away from the outside.
Can I come and ask for a question, please?
Yeah, I think Noor Alam is ready with his presentation. Ankit, can we go ahead with Noor Alam?
Yes, sir. Somebody was asking a question, sir.
Okay.
Yeah. Thanks for having me. I just wanted to ask. It's a very good paper. Suppose there's a patient who had this peroneus graft, and for some reason he has a re-rupture or a failed graft. What would you advise, to go for the peroneum on the opposite side or go for the hamstring?
Sir, I would suggest the peroneus grafting from the contralateral side, sir.
Okay.
As there is a very minimal morbidity in peroneus is there.
And I think the important thing is also, because when you start doing an ACL, make sure the wasting is quite adequately covered with the physio. Don't rush into doing a ACL reconstruction because there's an ACL rupture. You need to optimize it, get the flexion deformity, no contraction before you do. A nice paper. Thank you.
Good evening, sir. Am I audible, sir?
Yeah, you are audible.
Good evening. Myself, Dr. Noor Alam, presenting my research topic, Management of Clubfoot in Arthrogryposis Multiplex Congenita, AMC, a prospective clinical study. My guide is Professor Mazhar Abbas, sir, Professor, Department of Orthopedic Surgery, JNMC, Aligarh. My co-guide is Dr. Yasir Salam Siddiqui, sir, from Department of Orthopedics, Aligarh. Arthrogryposis multiplex congenita is a non-progressive syndrome characterized by rigid and deformed joint, diffuse muscle wasting with generalized reduction in muscle bulk, contracture of capsules and periarticular structure in at least 2 or more different areas of the body, but has a normal mental development. These are few of my patients with arthrogryposis multiplex congenita showing multiple joint contractures along with a clubfoot deformity. Similarly, here patient with multiple joint contracture, with hernia, with knee contracture, with CTV deformity bilaterally. Treatment of clubfoot in patient with AMC arthrogryposis is a challenge due to foot and ankle stiffness and deformity, severe deformity, the resistance to its correction, tendency to relapse, and with coexisting hip and knee fracture.
And mean age in the group here is 26.7. The mean age was significantly higher in group B as compared to group A. In group A, male was 69.2% and female was 38.8%.
Laird, Roberts, and Lettin describe the goal of treatment of AMC clubfoot is to convert a deformed rigid foot into a rigid plantigrade platform. There are only few published results, particularly in the Indian population. Hence, it is a high time for a clinical study of a clubfoot in AMC and its management, especially using the Ponseti method.
In our study, at the time of admission, neurological
sir, sound is echoing from
on the basis of ACR classification. ACR A grade were found in all the cases of both groups. At post-op, the A grade level found 8 and 85.2.
My aims and objectives are to study the incidence of AMC presenting in JNMCH to evaluate the effectiveness of Ponseti technique in them, and to study the possible causes of recurrence and to evaluate the various technical problems and suggest treatment options to manage them. In my patient, the majority of patients presented in the first 3 months of age, but there were 2 patients presented in more than 12 months of age. Most of my patients were bilateral, but few were unilateral, out of which left were most common. The pre-correction Pirani score came out to be 5.23, and the post-correction Pirani score after a successful treatment came out to be 2.07. Similarly, DiMeglio score, the pre-correction came out to be 15.8, ranging from 19 to 12, and post-correction came out to be 8.2. I have graded my patient according to DiMeglio criteria with benign, moderate, severe, and very severe form of CTV. The pre-correction, majority of patients were in severe to very severe form of CTV deformity. But while doing a Ponseti manipulation and casting, majority of patients was graded in benign to moderate form of CTV deformity. But few did not responded to CTV, like 5 patients were still in very severe form of CTV deformity. The percentage of AMC clubfoot among all the clubfoot patient presented in our pediatric orthopedic clinic was 4.76%. All the patients except 2 was less than 1 year of age. 19 orthogyrapedic clubfoot in 12 patients were included in my study, which were managed by Ponseti casting from November 2019 to November 2021. In my study design is a prospective study with an average follow-up of 1.1 years, with mean number of casts is 12.25. Tenotomy was required in all the 19 feet. Successful treatment, which is defined by a painless plantigrade feet, was 11 out of these 19 feet, which is around 58%. Relapses are also quite high, which is 42%. 8 feet was found to have relapse. Out of this, 5 got successfully treated again with recasting and tenotomy, but 3 didn't got corrected by casting or with tenotomy. So we need additional soft tissue procedures or other surgical procedures. Those who had failure of correction, we did TA lengthening or posterior release, plantar fascia release, or just frame fixation. Coming to discussion, my study is a prospective study of 19 feet, which is incomparable to other studies. But the mean average age of follow-up is 1.1 years, which is smaller as compared to other patients because of COVID lockdown. The mean number of casts is quite higher as compared to other patients, but the tenotomy was in all the patients, but the successful treatment, the percentage of successful treatment is higher and is comparable with other studies which have been done with AMC with CTV deformity. Coming to the relapse is seen in 42% of the patient, which were managed by J frame, tenotomy, posterior release, plantar fasciitis release, and other soft tissue surgery. Complications were also seen in my patient, like plaster soak, cast slippage, discoloration, green stick injury, eczematization, and also dynamic supination. These are few patients showing green stick injury, eczematization. We did TA tenotomy, quadriceps release, hamstring release, plantar fascia release, TA lengthening, other procedure along with CTV correction. These are pictures showing TA tenotomy, plantar fascia release, supracondylar extension osteotomy to correct the knee flexion contracture. This showing hamstring release of the patient. This is showing TA lengthening of the patient. And these are a few braces used in my patient, like Steenbeck foot abduction orthosis, ankle foot orthosis, wrist extension orthosis for correction of other deformity. So I conclude that AMC patient, the correction of CTV is challenging both to obtain and maintain correction. But from a study, we conclude that the Ponseti method of manipulation and casting is an effective treatment of these feet. But a greater number of cast, higher failure rate, and increased relapse are expected. But by treating this foot by Ponseti casting, we can bypass or that negative long-term consequences in terms of foot pain, ankle and foot osteoarthritis, and poor quality of life. So these are few of the case exhibit which seen in my patient. This patient with amyoplasia, that is arthrogryposis, which all the 4 limbs are involved, in which this patient presented in 25 days of age, and I started with CTV casting, and this is the latest follow-up with good correction. And for a knee flexion contracture, we did a supracondylar extension osteotomy. This is another patient with bilateral CTV with wrist deformity, which had relapsed after CTV correction, which was finally managed by correction by retenotomy. Another patient with knee extension contracture with CTV deformity, as seen here. We did quadriceps release along with CTV correction by Ponseti method, and this is good. This is the final outcome. Similarly, other patients which did not respond to the Ponseti method of correction, we required open surgical procedure like TA lengthening procedure as the final outcome of this patient. Similarly, a patient with more than 1 year of age, like 3 years of presentation, we required just frame fixation like this here, sir. Thank you, sir. Any questions, sir?
No, I think we can go ahead to the next.
Yes.
Dr. Aziz.
So look on this.
Yes, sir. Am I audible, sir?
Yeah, you are audible.
Good evening, sir. I am Adis Raza, going to present my research work on step cut osteotomy in post-traumatic cubitus varus and valgus deformity. My guide is Dr. Mohammad Zishan Khan, sir, Assistant Professor, Department of Orthopedic Surgery, AMU, Aligarh. So malunited supracondylar fracture result in cubitus varus deformity, while lateral condyle fractures result in the cubitus valgus deformity. So various corrective osteotomies are described, but there is no consensus have been made about which osteotomy is the best for correction of these deformities. My study was prospective study, which was conducted between November 2019 to May 2021, and my sample size was 10. And the inclusion criteria was a patient presented with cubitus varus and valgus deformities, which was cosmetically and functionally unacceptable. I have done my clinical evaluation by measuring the and comparing the carrying angle and range of motion in pre-op and post-op period. And radiological evaluation was done by measurement of the humerus ulnar wrist angle and lateral prominence index. All the patients were operated by posterior approach, that is triceps splitting approach. Here the triceps was splitted and bone was exposed, and then the triangle that to be osteotomized was marked, and osteotomy was done with the oscillating saw, and then it was temporarily fixed with the K wire, and final fixation was done with the recon plate. My results and observation: most of the patient was between the age group of 5 to 10 years. 8 of my patients were male and 2 of my patients were female. 9 of the patient has left side involvement, while one having right side involvement, and in all the patient right side was dominant side. The mean carrying angle in the cubitus varus deformity patients in pre-op was 25.25 degrees, while in the post-op period it was 3.37 degree, while the mean carrying angle in the normal side was 9.37 degrees valgus. Two of my patients having cubitus valgus deformity, and the mean carrying angle was 25.5 degree valgus in the involved side, and it was 12 degree valgus in the 12.5 degree valgus in the normal side, and in post-op period it was 12 degree valgus. So the mean angle of deformity compared to the normal side was 30.5 degrees in the pre-op, and in the post-op period it was 5.9 degrees, which was significant. So the range of mean range of motion also improved from 106 degrees in the pre-op to 114 degree in the 114.5 degree in the post-op, which was also found to be significant. The radiological measurement, that is humerus ulnar wrist angle in the cubitus varus patient was improved from 18.25 degree varus in pre-op to 9.8 degree valgus in the post-op, and it was also found to be significant. And the comparing the lateral prominence index, there was no lateral prominence, mean lateral prominence in the post-op, and the lateral prominence was found to be insignificant. Sir, I have calculated my result according to the open hem criteria, And in 4 of my patients, the result was excellent. And in the 4 of my patients, there was good result, and 2 of my patients having poor result. Now on discussion, I have compared my study on the previous studies in the step cut osteotomy, and the mean deformity in the pre-op post-op periods is comparable to the previous studies. In the range of motion is also comparable with the previous studies. The humerus ulnar wrist angle in my patient is change in humeral ulnar wrist angle is also significant like the previous studies. And sir, there is no lateral bony prominence in sir, any of the studies as well as in my study. Sir, and the results which was calculated according to the open hem criteria is also comparable to the previous studies. Sir, the step cut osteotomy is uniplanar osteotomy that corrects only coronal deformity and doesn't correct sagittal and rotational deformity. Sir, Takaji et al. Reported no significant difference between the patients underwent coronal plane and rotational correction with the patients who had underwent only coronal plane deformity. And sir, hyperextension need not to be corrected when correcting coronal plane deformity in the patients with less than 10 years of age, as sagittal plane deformity corrects and remodeling occurs with time. The complications, one of my patients had iatrogenic radial nerve palsy, which recovered on the 3 months of follow-up. So 2 of my patients had the poor outcomes. One of this patient has the 15-degree loss of arc of motion in the post-op, and one of the patient has a residual varus deformity of 5 degrees in the post-op. Sir, limitation of my study, my sample size was small when compared to the other studies. And sir, the step cut osteotomy is uniplanar osteotomy. It doesn't correct sagittal plane and rotational deformity. Sir, and the follow-up could not be done properly due to the COVID pandemic. Now on the conclusion, a step cut osteotomy corrects the post-traumatic cubitus varus and valgus deformities with gain in the range of motion without causing any lateral bony prominence. Thank you, sir. These are my
Any questions?
Hello. Hello.
Any questions?
Yes, Dr. Adi. Hello.
Yes, sir.
Hello.
Yes, sir.
Dr. Adi.
Yes, sir.
I have a question.
Yes, sir.
Do you have considered in your study regarding stiffness of the joint?
Yes, sir. The range of sir, sir, in the pre-op period, when the patient presented to OPD, sir, initially physiotherapy was advised, and sir, after 2 to 4 weeks of physiotherapy, we operated the patient, and sir, then the physiotherapy was started after 2 weeks in the post-op period. Sir, the physiotherapy was started after 2 weeks on the stitch removal, and slab was removed.
Okay. And one thing I have, you have said that you have used in all your cases recon plate.
Yes, sir. Yes, sir.
So what is the criteria for using recon plate in all the cases? Is there any difference in applying plate in pre-adolescent group or beyond the adolescent group?
Yes, sir. Because sir, recon plate.
Because I have gone through the Kim et al. Paper. He has used in K-wires, cross K-wires, and SS wire in pre-adolescent group.
Yes, sir.
So, have you considered this or not?
Sir, in most of the paper, they have used either decon plate or sir, Y plate for the fixation.
Yeah, Kim et al. Has
Yes,
used
sir.
Y plate in most of the cases.
Yes, sir.
But in pre-adolescent group, he has used cross K-wire and SS wire fixation.
Yes, sir. So decon plates provide better fixation so that we can start physiotherapy initially after 2 weeks.
But I think by recon plate, you can only stabilize one column only.
Yes, sir.
Either lateral or
Yes, sir.
medial.
Yes, sir.
But Y plate will give both column stability, and you can go for early mobilization.
Yes, sir.
Thank you. It was really a very nice presentation.
Okay, we can switch over to next candidate. That is
Faisal. Hello. Good evening,
Hello.
sir. Am I audible?
Yes, yes, carry on.
Good evening, everyone. I am Dr. Fazal Ahmed and presenting my thesis topic, Management of Distal Tibial Fractures, a Clinical Study. My supervisor is Professor Amir bin Sabir, sir. Coming to the introduction, the incidence of distal tibial fractures is 3 to 10% of the all tibial fractures of the lower extremity. Sorry. It may be either extra-articular, partially intra-articular, or completely intra-articular fracture. Distal tibial fractures may be caused due to high energy trauma like the road traffic accidents, fall from the height, or low energy trauma like the twisting injury. Up to 50% of the distal tibial fractures are open, but significant soft tissue injury occurs in closed fractures as well. Management of distal tibial fractures is a therapeutic challenge for orthopedic surgeons. The goal of the treatment is to restore the tibial anatomy, to fix the epimetaphyseal block with the diaphysis, and to avoid complications. These injuries are particularly challenging to manage due to the limited soft tissue coverage, poor vascularity of the area, proximity of the fracture to the ankle joint, and associated soft tissue injury. Management of distal tibial fractures is still debatable in literature. Treatment depends on the type of fracture, comminution, and soft tissue injury. Different treatment modalities described for the distal tibial fractures are open reduction internal fixation with plating, closed reduction internal fixation with the nailing, external fixator application, limited internal fixation with K-wires or screws, stage surgery, minimally invasive plate osteosynthesis, and conservative treatment. Now coming to the classification system used for the bone injuries are OTA classification, which is X-ray based, and it is used for both intra and extra-articular fractures. Topless classification, which is CT based, and it is used for the intra-articular fractures. Classification for the soft tissue injuries are Gustilo-Anderson classification for open injuries and Osten-Zernick classification for closed injuries. This chart is showing the AO classification of the distal tibial pylon fractures, which mainly divides into 3 types: A1, A, B, and 3. A is further divided into A1, A2, A3, depending upon the geometry. B also divided in similar ways, and C also divided in similar ways. This chart is showing the topless classification, which mainly divides fractures into sagittal and coronal family. Sagittal is further divided into sagittal split, inverted V, T type. Coronal is divided into coronal split, anterior split, posterior split, V type, and Y type. This chart is showing the Gustilo-Anderson classification of the soft tissue, open type of soft tissue injury. And this is Osten-Zernick classification of closed soft tissue injury. Now coming to the need of the study, different treatment modalities are available for the distal tibial fractures. Not a single modality is sufficient to take care of all types of fractures. In our study, we will use different modalities of treatment based on the classification, skin condition, severity, and fracture pattern, and note the functional outcome in each. Thus, we will try to devise the treatment algorithm for different types of distal tibial fractures. The aims and objectives are to study the incidence of different types of distal tibial fractures, to study the different modes of injuries in the distal tibial fractures, to devise treatment algorithm for different types of distal tibial fractures, and to study the complication associated with the management of the distal tibial fractures. Coming to the materials, this is a prospective study conducted on patients with distal tibial fractures treated with different modalities in the Department of Orthopaedic Surgery, JNMCH, AMU, Aligarh, from November 2020 to November 2022. We propose to include a minimum of 15 patients in our study. The inclusion criteria are patient with distal tibial fractures, skeletally mature patients, fractures less than 3 weeks old, Gustilo-Anderson grade 1, 2, 3A, 3B. The exclusion criteria are pathological fracture, polio limb, any other congenital limb deformity, and vascular injury, that is Gustilo-Anderson grade 3C. In pre-operative evaluation, we will do clinical assessment by history and examination. If patient was found suitable, was briefed about the treatment type of treatment, and written informed consent was taken for the same, and details of the patient taken according to the performer. The basic blood investigations like complete blood count, renal function test, triple test was done. X-ray of the ankle joint, anteroposterior lateral mortise view, and whole leg anteroposterior lateral view was done. CT of the ankle would be done only in the intra-articular extensions. Fracture would be classified according to AO classification, further by the Topless classification if intra-articular. Soft tissue injury classified according to Gustilo-Anderson classification, open soft tissue, and Austin-Zerner classification, closed soft tissue injury. Depending on the classification, skin condition, severity, and fracture pattern, appropriate treatment modality chosen for patient on case-to-case basis, and depending on the fracture pattern on X-ray and CT, appropriate surgical approach would be chosen. Surgical approach, different surgical approaches to distal tibia, anteromedial, anterolateral, extensile anteromedial approach, lateral approach, posterolateral, posteromedial, and minimally invasive approach. The follow-up would be done by regularly in the OPD at 2 weeks, then 6 weeks interval till union, and then 3 monthly. Clinical assessment would be done by AO FAST score and soft tissue complication infection, and radiological assessment would be done by seeing the union and alignment. This chart is showing the AO FAST score, which divides the result into 4 types. Less than 70 is poor, 70 to 80 is fair or acceptable, 80 to 90 is good, and 90 to 100 is excellent. Now coming to some exhibits. This is first patient presented with distal end tibia fracture with orbital 5 fragment with fracture left lateral malleus. This is pre-op and post-op X-ray, and this is follow-up X-rays. This is next patient, pre-op, post-op X-ray. These are follow-up X-rays. This is third patient. These are pre-op, post-op clinical X-ray. These are follow-up X-rays. These are clinical pictures. Fourth patient, pre-op, post-op X-ray, clinical photo. Fifth patient, pre-op, post-op X-ray, follow-up X-ray. Next patient, pre-op, post-op X-ray. These are follow-up. These are clinical images. Next patient, this is pre-op, post-op X-ray, clinical photo. Next patient, pre-op, post-op X-ray, follow-up X-rays, clinical images. Next patient, pre-op, post-op X-ray, follow-up X-rays, clinical photo. Next patient, pre-op, post-op X-ray, follow-up X-rays, clinical photo. Next patient, pre-op, post-op X-ray. Next patient, pre-op, post-op X-ray, pre-op, post-op X-ray. Next patient, pre-op, post-op X-ray. Next patient, pre-op, post-op X-ray, clinical photo, pre-op, post-op X-ray. These are follow-up X-rays. These are clinical photo. These are pre-op, post-op, follow-up X-rays, clinical photo. Coming to the results, the minimal follow-up was 1.5 months with an average follow-up 6.85 months, range from 1.5 to 13 months. The demographic data were similar in the different osteosynthesis group. However, regarding the injury data, we noted that external fixation was used mostly for the open fractures. The p-value was less than 0.02. Surgical complications occurred in 4 patients, that is 23.5% of the patients. Superficial skin infection in 1 case, deep infection in 2 cases, and non-union in 1 case. The complication rate was significantly higher for subgroup 3 according to AO-OTA classification than subgroup 2 or 1. This rate was also significantly different according to the osteosynthesis type. Using the AO FAST ankle hindfoot scale, the average functional score was 66.35 points, range 40 to 94 points. Results were excellent in 5 cases, good in 4, fair in 1, and poor in 7 cases. These poor in 7 cases are due to the less follow-up duration. The 9 patients had follow-up of more than 6, and in them AO FAST score was excellent in 5 and good in 4 cases. This chart is showing the age distribution. 8 of the patients were 18 to 40 years and 9 of the patients were more than 40-year age group. This sex incidence, 13 were males and 4 were female. This is mode of injury. Most common mode of injury was RTA, followed by the fall on the surface, then fall from height was 1 and fall of heavy object was 1. Type of fracture, closed fractures were 11 and open were 6. This chart is showing type of fractures according to AO-OTA classification. The most common type was type A2, followed by the type A3. This is showing the injury treatment interval. 8 patients were treated within 3 days of the injury, 3 patients were treated within 3 to 5 days, and 6 patients were treated more than 5 days after the injury. This chart is showing the procedure done. 7 patients were treated by internal fixation. 1 patient was treated by limited internal fixation with K-wire. 3 patients were treated by external fixation, and 6 patients were treated by intermedullary nailing. This is chart is showing time to callus. 6 patients developed callus within 8 to 12 weeks, and 7 patients developed after 12 weeks of the surgery. Time to bony union. 5 patients developed bony union within 12 to 16 weeks, and 6 patients developed after 16 weeks of the operation. This is showing the complication. 2 patients developed deep infection, 1 patient developed superficial skin infection, and 1 patient developed non-union. And 13 patients do not develop any complication. This is follow-up duration. 8 patients had duration less than 6 months of follow-up, and 9 patients had more than 6 month duration of follow-up. This trend is showing the AO FAST trend. Pre-op, post-op, 6 weeks, 3 months, 6 months, 9 months, and 12 months. When we consider all the patients, the OFAS score was excellent in 5 patients, good in 4 patients, fair in 1, and poor in 7. But when we include the patients only with follow-up duration of more than 6 months, then excellent in 5 patients and good in 4 patients. Now coming to the discussion, this prospective study of 17 patients confirms the difficulty of distal tibia fractures management and the high complication rate. Post-operative complication concerned 23.5% of the patients and were mostly infectious or cutaneous problems and non-unions. The rate is comparable to the other series with rate ranging from 20 to 50% in different studies. As others have pointed out, we found a correlation between the complication rate and initial fracture severity. In the same way, high fracture severity complications and malunions were associated with the poor clinical results. The best clinical results were observed for limited internal fixation group. Open reduction in internal fixation with plate permitted a correct and stable fracture reduction with good clinical results without any increase of the cutaneous or infection complication rate, or on contrary to the other authors. For the external fixation group, no two-stage protocols were undertaken in this study, and external fixation was always a definitive device. Similar to many other studies, we found that definitive external fixation provided more malunions, stiffness, or pain than open reduction internal fixation. Thus, we believe that external fixation should be preferentially used in two-stage protocols or as a temporary device before open reduction internal fixation or limited internal fixation. Our ipsilateral fibular fracture rate was 100%, which was more in comparison to the rates 80% found in literature. We recommend a fibular osteosynthesis with plate as often as possible in order to restore the length of the tibia, to control the rotational forces, and to avoid valgus malunion. Minimally invasive plate osteosynthesis was used in 17.64% of the patients. Minimally invasive plate osteosynthesis reduces soft tissue damage and preserves the bone vascularity and fracture hematoma. However, there are some complications with this method. Lau et al. Found 15% with the late infection, and 52% of the patient underwent hardware removal for skin impingement. In addition, there is important risk of saphenous nerve and great saphenous vein injury during the percutaneous screw placement. Distal tubular fractures are complex cases and need appropriate treatment to limit the incidence of complications. For acute fractures without skin injury, we prefer a stable and rigid internal fixation in one-stage procedure. Limited internal fixation can be used for fractures without important combination and easily reducible by traction or external manipulation. However, with this technique, a non-weight bearing cast is recommended. Open reduction internal fixation with conventional or locking plate should be used for comminuted cases in order to reduce the articular surface perfectly. One advantage of the locking plate is to permit faster full weight bearing and stronger fracture stabilization as an internal fixator. For fractures with skin injury, important soft tissue edema, or delayed surgery, we recommend a two-stage protocol similar to that of many other authors. The first stage consists of an approximate reduction and application of external fixator spanning the ankle joint. The second stage is delayed from 7 to 10 days until soft tissue recovery and consists of an open reduction and internal fixation. External fixation should not be used as a definitive device. We limit the use of intramedullary nailing to extra-articular closed fractures. The limitations of the study are multiple surgeons involved and multiple treatment methods. There is a selection bias in our study because the injury mechanisms were more severe in external fixation group compared with the other groups. Thus, functional outcomes in the external fixation group were probably underestimated. Another limitation is that the follow-up of this work did not permit the study of the long-term complication of osteoarthritis. Coming to the conclusion, distal tibial fractures remain a therapeutic challenge for orthopedic surgeons. According to the literature, these fractures are often associated with the high complication rate. Based on our study, when using external fixation, the complication rate is higher and functional outcomes are worse. We believe that external fixation must be reserved for trauma with severe skin injury as a temporary solution in two-stage protocol as described by Sirkin et al. For other cases, we recommend open reduction internal fixation with early mobilization. Further prospective randomized trials with longer follow-up are required to determine the optimal treatment strategies for these injuries with more accuracy. These are my references. Thank you, sir.
Thank you, Fazal. Any questions from the chairpersons?
Hello.
Any questions?
Hello.
Hello. Any questions?
Hello, Dr. Fazal.
Yes, sir.
It was really a very nice presentation.
Thank you, sir.
I think it was a very vast study. One thing I want to ask you, how many cases you have used anterolateral approach for distal tibial fracture?
Sir, in 3 cases.
How
anterolateral, sir.
Yeah.
In 2 cases, sir. In 2 cases, sir.
In 2 cases.
Yes,
what is the criteria for deciding whether you go through anteromedial or anterolateral?
Sir, it depends on the fracture geometry, on X-ray and CT if required.
So how fracture geometry, how you decide on the basis of it?
Sir, if comminution is more on the lateral side, then anterolateral approach, we need more exposure on the lateral side. So we use anterolateral approach. If comminution is more on the medial side, then we use medial or anteromedial approach.
Okay. Is there any in any of the cases you have gone through wound dehiscence on the basis of approach?
Wound dehiscence didn't occur. In one patient, there was superficial infection, and in two patients, there was deep infection up to the bone.
Which one is better in your experience?
Sir, it depends on case to case. If skin condition is good and we can go for, if skin condition is good and there is minimal swelling, then we can go for definitive internal fixation by MIPO technique or by G. If skin condition is not good, we can go for external fixation also.
Okay.
I think thank you, Fazal. But my last suggestion is that whenever you are presenting a PPT, you have to be very concise. You don't have to go much for so much of literature. And you have to be very concise. Try to read in between the lines, please. Okay. Take care in future. Thank you. Thank you. I think thank you everybody. Thank you, Ankit. And thank you, Ajay. And thank you, everybody. Am I audible?
Thank you.
Thank you. Ankit, thank you.
It was, you have organized a very...
Thanks very much. Thank you, everybody. Sir,
Thanks all the chairpersons.
Dhawan sir.
And all the faculty.
Welcome, sir.
आजा सर बैठो आप फोटो भेजिए फोटो मैं वही तो
Dhawan sir एड्रेस कर दीजिए थोड़ा सा लास्ट में
नहीं थैंक यू इट्स वेरी वेल ऑर्गेनाइज्ड एंड आई कांग्रेचुलेट टीम